mocha mu gitaramo nkabimbanza bigutya
kandi nirarire tangabo kukize baze bacamo kunguru naziginze bagabo bambaye yamwe ntasindinzi yamwe bahungu muje kirenge bagabo bampaye nka iyo mwiriwe ntarongoye
rwa ntabwo
mbona ruhameye
uyu ni ruhame mureza makuza batarangira umuhanzi yamwiza
wone bahanda baruhame harame nikufuri ya parika niko ntacyo ndagenda urufunguzo wari urwogikeye ngo wari urwakigarama ndi umuhigira benzi warugina abasore barahamba rusha gushyamanga ubundi waje mureza makuza rugina amacuba arwana ishyaka
urabona rwikona makuza rw'umukino z'urubukobanya n'imbere y'ingoya yanga karwana ikibereze kimahe
hano n'ibishinga imigereka unicyogereye kumubona ngombe ntabazanya mugenda mubi imbere nagenda mubi nyuma y'icyaduka bakagana
aho nibonye mboneza bakuru
Thank you once again to the Indizi Cultural Group. Another round of applause for them. Yes, such a powerful and grounding performance. Now, without further ado, Africa Mena Brain Week. Sorry. Yes. So Africa Mena Brain Week exists because of a clear vision and committed leadership. It is my pleasure to invite the organizer of Africa Mena Brain Week, Mr. Tunga Abdul Ndame, CEO of Global South Connect, to deliver the welcome address. Round of applause.
Thank you very much. Good morning, everyone. Dr. Darius Gishoma, your distinguished professors, Mahmoud Homeda, honorable professors, doctors, good morning, everyone. It's a true honor and a privilege to welcome you all to Kigali in this beautiful city, a nation of thousand hills, a land that symbolizes resilience, vision, and transformation. My name is Tunga Abdul Ndame, based in Copenhagen, Denmark. I'm the CEO and founder of the Global South Connect, an organization we founded with our friends in the diaspora to connect the Global South countries to the Global North countries. Our organization stands, as it says by its name, to make sure that we create connections, gatherings like the gathering we have here, but gathering that make a difference on women, girls, and underprivileged in the Global South countries. Today, I stand before you. I'm filled with pride, gratitude, and hope. Pride because we are gathered here among some of the brightest minds, dedicated health professionals, researchers, advocates, and future leaders. Gratitude because your presence shows commitment to knowledge, collaborations, and progress. And hope because gathering like these remind us that real changes become possible when people come together with a purpose. When we created this organization, this was our goal. Seeing you all gathered here, it's really fulfilled our dream and vision. This conference taking place here in Kigali is a living example of that vision becoming a reality. Over the coming days, we are not simply attending a conference. We are building bridges, we are exchanging ideas, we are strengthening partnerships, and we are planting seeds that will grow into research breakthrough, improved healthcare systems, and stronger collaborations. Our goal for this week-long gathering is simple, that single participant returns home carrying something valuable, new knowledge, new friendships, and professional connections that will continue to grow long after this event. And today, our voices and discussions are not limited to these rooms alone. This conference is being followed live across multiple digital platforms, reaching beyond Rwanda. We are followed by students, researchers from Karachi in Pakistan, Casablanca in Morocco, London in Nigeria, Ouagadougou in Burkina Faso, Copenhagen in Denmark, and of course in the United States. And in this room, all the people or all the countries that I just mentioned are represented. We have speakers who are coming from more than 12 countries. So this is a huge experience, an experience that will impact on people's lives in different parts of the world. Today, we celebrate the fourth Africa Mena Brain Week, a remarkable initiative that brings together researchers, patient organizations, doctors, and students from across the region and the disciplines. This week represents more than scientific discussions. It represents collaboration across continents. It represents recognition that brain health is not a regional issue, but a global priority. The challenges facing global health today are complex, but they are not impossible to solve. They require courage, they require partnerships, and above all, they require shared belief that every life deserves access to quality healthcare and scientific advancement. Let this conference not only expand what we know, but transform what we do. Let us strengthen collective commitment to women, girls, and communities across the global south. Let it remind us that when knowledge, compassion, and collaboration comes together, they create a real and lasting change. So let's get together and climb higher. Together we can see further, and together we can build a healthier, more inclusive future for generations to come. Thank you very much. I wish you all a successful and inspiring 4th Africa Mena Brain Week.
Thank you very much, Mr. Ndame, for that vision and for your leadership in bringing this important platform to life, which I'm sure we're all going to learn a thing or two from. So hosting a conference of this scale reflects a strong commitment to science, education, as well as collaboration. I now invite the Chancellor of the University of Medical Sciences and Technology, Professor Mamoun Homeida, to deliver his welcome remarks. Round of applause.
Welcome to the UMST University of Medical Sciences and Technology. I would like to acknowledge the presence and greet the representative of Ministry of Health, the Rwandan Medical Council, and those who came from far away, the Society of Africa Mena, the President, and the members, all the professors and academicians, scientists, researchers. We are very pleased to be able to host with the Minister of Health this conference, which we think is important. We are in the world today with eruption of wars everywhere. I think we need to have a gathering like this. It's very important to come together as human beings and discuss how we can develop our health, our nation health, and go forward. It is important that we build together a future for our children and grandchildren. And this is how we see these activities coming in a university. Universities are for development, research, and dissemination of research. And this is well in the line of dissemination of research. So welcome again. And I would just like to take 3 minutes to highlight some of our worries as far as neurology neurological sciences are concerned. We are in a time very lucky to have very advanced imaging techniques like MRI, CT, ultrasound, and biochemical and immunological techniques. This has really revolutionized our concept, our understanding, and our research in neurology. Those like us who lived the era before the MRI would know that clinical acumen was the only diagnosis which we have to diagnose neurological diseases. Now we are far better positioned to do much more for the patients having had these techniques in our hands. In Africa, we lack research, and this is very important to highlight it here in this sort of conference. We should go back with enthusiasm to do research. We have to depend on young people, okay? Because I'm sure they think better, they have endurance, and they have will to proceed into new research arena. Neurology, this triangle of brain, heart, and blood has been studied very carefully in many parts of the world. The cerebrovascular accidents, which is plaguing Europe and America, is high up in these countries in Africa. We have noted that the age is at a younger age group. Infection is common. We're still suffering from encephalitis of malaria. Luckily, some of the diseases are disappearing, like trypanosomiasis, the rhodesiensis and gambiensis, and nodding disease of onchocerciasis is also diminishing. But we still are suffering from many infections. Zika virus is spreading in many parts of tropical countries. We have to do a lot of research to guide us to how we can build our future in medicine. So neurology is very important. My words is just to direct attention to the local factors in Africa and the North Africa, particularly because at the end of the day, what benefits us is research done in our countries. So this is extremely important. I would like to thank the government of Rwanda. You have already seen how beautiful, tranquil, quiet, and peaceful this country is. And on behalf of the Rwandan population, welcome you to this country. And I hope we have a continual and sustainable relationship with all those who attended this conference for the future of our younger generation. I would like to thank you very much indeed for being with us here. Thanks to the organizing committee who have done a good work, and I wish you good deliberation. Thank you.
Thank you very much to the Chancellor of this university for your welcoming and insightful remarks. Now, scientific leadership and regional collaboration are at the heart of Africa Mena Brain Week, as we're going to experience throughout the course of these few days. It is my honor to invite the president of the conference, Professor Najib Kisani, to deliver the official opening address. Round of applause.
So it's my great pleasure. I don't know if I can have the slides. Okay. So thank you very much. It's my great honor to be with you here. And it's So it's the first time, I hope that my slides are coming. So first time that our Brain Week is going outside Morocco, because we started it 2023, first edition in Morocco. And we're really very happy, and thanks to all of you, thanks to Minister of Health, thanks to Professor Obeid from the Dean of the University, UMST, thanks to the committee organizing this big event. I think Mr. Abdullah and Mrs. Chantal, I think they work very hard. Of course, we've been assisting them from Zoom from day to day, Professor Shuho, myself, Professor Suleimani, and Professor Ali from Pakistan. And also this is the scientific committee. Thanks also to all the sponsors. And I think we will go through my presentation. Rwanda is a very exciting country. It's my second time here. I've been here in 2023, just after the borders have been opened after COVID. So it was very hard time. So first time to visit Rwanda was 2023. And we met, of course, with Chantal, with all her team. We did a lot of training sessions for nurses, for GPs. I'm mostly involved in epilepsy and telemedicine. So Brain Week started 4 years ago. And as you can see here, we can just tell you how the idea of Brain Week comes. So first of all, we've been organizing conferences for more than 25 years in Morocco, in many African countries, Senegal, Mali, Ivory Coast. First time in Rwanda. And we've been asking ourselves, why not to expand our conferences not only to neurologists, because we've been very close, limited to neurology, sometimes neurosurgery, psychiatry. And we said, why not to open it to other colleagues, and not only physicians and specialists, but also patients and associations. And thanks to Chantal, because we met in 2017 in Thailand. It was a big conference of epilepsy. And she is the president of Epilepsy Association in Rwanda. She's doing a very, very good job. And we said that why not to create one group of association of patients. And I think the work started since 2017. So I think we said that not only specialists, not only GPs, not only nurses could be involved in organizing conferences, but we need also patients, especially that patients are the main target of all our attitudes, our work, treatment, everything will finally end in patients. So no need to just meet with specialists to discuss, and the patients are removed from that group. And as you can see, we organized a lot of things, but why? So that's the first Brain Week. I don't know if we can click on the, can you click on the link, please? So that's the first edition, connecting neurologists, neurosurgeons, psychiatrists. It had been produced in Marrakesh, February 2023. So that was the first edition. If we can click on the link. Can you please click on the link there? So I think just to... So just to give you an idea about the first edition. The first edition of this Brain Week, which had more than 25 countries at that time. You can just see a few pictures. Of course, we had many countries from Africa. We had, of course, Rwanda. We had Burundi. We had Uganda. We had Tanzania. We had Mali, Senegal, and many countries from Mena region. So I think you can maybe see some pictures of that first event organized in February 2023. And of course, it was the first edition. Of course, we had a lot of things to adjust. That's why we went to the second Brain Week. Yes, if you can just open that link. Yes, so just click here, please. So you can see the first Brain Week. It has been organized in Marrakesh. You can see we had also patients. By example, this is Mr. Aitkero. He's patient with Parkinson, and he was the one who produced the logo of the conference using AI. So just to tell you how strong can be the collaboration with patients and with families and associations. Can you go? So here, all the conferences, and also we had a lot of workshops produced by patients. All these are patients with epilepsy, with Parkinson.
with very early stage of Alzheimer, producing a lot of jewelries, painting. I think that's a very good way of helping patients, of encouraging patients, of fighting stigma. I think that's also a very good experience that we learned from the first edition of Brain Week. So you can see here all the events that we organized. Of course, I think we can close this one and go to the second Brain Week. So the second Brain Week, so second was organized in Demnat, which was a city in mountains in Morocco. We had 50 countries represented. And the third one was just organized last year, 2025, February in Rabat. We had around 100,
more than 280 participants. And also we had 70 countries represented. We had professors from China, from Japan, from India, from Russia, from Pakistan, of course. And we had big events so that you can see. And that conference was organized in that national institute. So it was the first national institute of science in Morocco. And we celebrated the 100th anniversary of that institute in Rabat. So you can see here the flags of all countries represented. Can we move to the second one, please? Yeah, so that's the third event.
So that's the third event we organized in Rabat last February. Of course, we've been very happy. We had colleagues from more than 70 countries. It was not that easy to welcome 70 countries. And we had been honored by the visit of the ambassador of Rwanda in Rabat. I think we had 7 ambassadors participating and the 3 in person, Rwanda and Tanzania. You can see here a lot of experts. For example, we had Professor Alagert from Russia. She's the president of International League Against Epilepsy. We had Professor Fujiwara Kazuo from Japan, and we had many, many others. We had 4 professors from China. And you can see that we had also lots of meetings, lots of workshops that we organized. Here you can see a lot of our experts. Professor Gallo Diop is a well-known epidemiologist from Senegal. And also we had lots of activities, workshops. You can see here Chantal and our colleague from Tanzania. Here our experts from China. So it was very, very successful conference. So why Rwanda? Of course, Rwanda is a very developed country. My second time here, and I think the Ministry of Health is doing a very good job. So we find that there are a lot of developments, especially in primary healthcare system. So I think it's also a good model to be reproduced in other sub-Saharan African countries. And also Rwanda and Morocco has very good relationships. So our king came 2 times to Rwanda and met with Sir President Mr. Kagame. I think that's a very nice picture. And here, so we want to bring our warm thanks to, of course, local organizing committee, Mr. Abdullah. I think he did very, very good job. Mrs. Chantal also, and all the team around them. I think we can applaud them. MOH, of course, for allowing this to happen. I think our colleague met with us many times by Zoom. I think it was not that easy, not only for colleagues in Rwanda, but also for us from Morocco, from Pakistan, from UK, from France, from other countries. We met nearly last time. We met twice a day sometimes till very late in the evening to finalize the program and everything. We thank all the staff of the UMST. I think it was a very nice place. Thank you very much for hosting us here. I think we are really amazed by this very nice institution. Thanks to the scientific committee. I think we are around 10 professors, but I think we worked with many, many others. And also thanks to our sponsors. The Partners in Health are the major sponsor, but we have also others. We have the UMST, we have the Epilepsy Alliance Africa, we have Charity of Germany, I think, who is also sponsoring this event, International League, and many others. And in the end, I want just to say that it was really a great success to have the 3 previous editions of Brain Week. And I'm really confident that this 4th edition
will be also a very big success. And we will see you very soon, of course, after this big event, inshallah, to go properly and to end. Inshallah, everything will go ahead as it has been planned. And we have already 4 candidates for the 5th Brain Week. We have Bamako, Mali, with Professor Yusuf Amaiga. We have Muscat, Oman, with the professor from Oman, and also Professor Suleimani, who is supportive. And we have also Ben Ghadir from Morocco again. But even myself, I'm not encouraging to bring it back to Morocco. Maybe we can make alternative between MENA, which is North Africa, Arab countries, and Africa. Maybe after 7th or 8th, we can come back to Morocco. And we have also Baghdad, Iraq. And thank you very much and welcome everyone.
Thank you very much to the president of the conference, Mr. Najib, for that presentation, for showing us how the previous Africa MENA Brain Weeks have been, as well as showing us why they chose to come to Rwanda, highlighting the great relationship the two countries have. Now, without further ado, this moment marks the official launch of the Africa MENA Brain Week 2026 and reflects Rwanda's continued commitment to brain health and mental well-being. On behalf of the organizers, it is my privilege to invite our guest of honor, Dr. Darius Gishoma, Division Manager at the Rwanda Biomedical Center, to officially launch Africa MENA Week here in Rwanda. Round of applause.
Dear Chancellor of UMST, Professor Mamoun, dear Professor Najib Kisani, the president of this conference, dear Professor Stefan Janssen, the president of the local scientific committee, dear Professor Vincent, Mr. Tunga, and Chantal that led the organization committee at local level, Mrs. Nadine Karema, Executive Director of Partners in Health in Rwanda, who played a big role in facilitating this conference. Dear Marie-Rose Kairangwa, Country Director of JPIGO, who is also supporting a number of initiatives in this field. Distinguished guests, dear researchers, doctors, nurses, stakeholders, patients, colleagues, ladies and gentlemen, good morning. On behalf of Honorable Minister of Health and Director General of Rwanda Biomedical Center, it is my great honor to welcome you all to Kigali and to this 4th Africa MENA Brain Week in Rwanda. The Minister of Health wished to be here himself, but as you heard, we have an important gathering in the country called the National Dialogue, Umushyikirano, where top leaders from the head of state meet with all leaders up to the head of the village. He wished to be here, but he asked to be kept informed of progress we are making. And as the National Director of Mental Health and Neurological Programs, it is my honor and pleasure to address you today on his behalf. We started with a stress and patience test, but I think you all brilliantly passed the test. And the traditional dance was like a stress relaxation, so I won't take you long. I'll maybe make 2 main comments to allow the discussion scientific discussion to happen. My first remark is I would like to first express the Ministry of Health, Rwanda Biomedical Center gratitude to all people who have been involved in the organization of this Brain Week in Kigali. Professor Najib Kisani, Professor Abdullah, Professor Sulamani, that I had a privilege to have a very good conversation about initiatives that need to happen in Africa globally. Thank you for choosing Rwanda as the host of the 4th Africa Brain Week. And as Professor Kisani mentioned, there are so many reasons he mentioned. I wanted to highlight that Rwanda has exceptional high burden of mental health problems due to consequences of the genocide against Tutsi. In addition, and I think Professor Sebera Fidel will probably talk about it, the prevalence of epilepsy in Rwanda is among the highest in Africa. Etiological studies need to continue to explain a number of factors. So the first reason is that we have a high burden of mental and neurological conditions. And on the other side, over the last 3 decades, Rwanda put a lot of effort to make available brain health related services, including decentralizing services up to the level of health centers. We are still having challenges. The number of neurologists per 100,000 population is still low, but the efforts are continuing. Hosting this important scientific and public health event in Kigali also reflects Rwanda's growing role as a regional hub for health and innovation, medical education, and global collaboration, and to also sign a strong commitment by African countries, especially those in the global south, to shape their own solution in brain health. This is the first Brain Week in Rwanda, and we hope it is not the last. We saw a list of 4 candidates, and we hope that in the future we may host another Brain Week in Kigali. Professor Mamoun Homeda, Vice Chancellor of UMST, thank you for accepting to host this conference. UMST is an important partner for the Ministry of Health in the field of health workforce development, but also in research and clinical practice. And we are happy to have your collaboration in organizing this type of event. And thank you so much for what you are doing in Rwanda. A special thank and welcome to speakers, as you heard, from 12 countries. I had also 15 countries from Professor Kisani, who came to share their knowledge and expertise. It is my hope that you would not only have stimulating discussions on brain health, but you also have the time to enjoy the country and visit the country of 1,000 hills. I also wish to recognize the contribution of different partners, PIH and others that have been mentioned. Thank you for your support that helps on a daily basis to provide health services that people in our community need to thrive, but also to contribute to organizing this beautiful conference. My first comment was to thank all organizers and the role you play to have a successful conference. My second brief comment will be to talk about the importance of Brain Week and advancing brain health in Africa. There is a significant pivotal moment for brain health globally and in Africa. 3 weeks ago, the 15th of January 2026, the World Brain Health Forum was held in Paris. It was inaugurated by Dr. Tedros, the Director General of WHO, and His Excellency Ban Ki-moon, former Secretary General of the UN. One of the key highlights from that World Brain Health Forum was that brain diseases are currently considered as a major challenge for the 21st century. According to WHO and key epidemiological findings, brain diseases, mental health, epilepsy, stroke, neonatal encephalopathy, migraine, dementia affect approximately 3 billions of people worldwide. 1 in 3, 1 in 4 people experience a brain disorder at some point in their lives. And this reality is identified by the World Health Organization as a major public health priority, and it calls for unprecedented international collaboration and mobilization like this we are having here. At the same time, all brain health leaders, including those the most significant challenges affecting brain health and to advancing brain health, events like this, Brain Week in Africa, are critical to strengthening prevention, especially modifiable factors that what we're discussing with Professor Suleimani, early diagnosis and treatment. You saw a very interesting agenda with different areas of focus, including PTSD, stroke management, epilepsy, pediatric neuroscience, EEG, brain surgery. All of these are important discussion to have to improve prevention, early detection, and treatment. It is also commendable that this Brain Week provides a unique learning opportunity for medical students. I heard that probably up to 40% of people attending are medical students, nurses, and this is important. We also have patient association, and this Brain Week gathering encourage not only academic dialogue, but also community involvement. On the agenda, we have the attending to the Car-Free Day Sunday. That is important, and it highlights also that physical activity and well-being prevention are pillars of brain health. In the end, brain health must be a personal, family, societal, and global health priority. It is largely known that the human brain is the command center of systems that enable thoughts, emotion, behavior, decisions, project, movement, and improving brain health ultimately enhance productivity and quality of life for individual, families, and society. As I conclude my remark, I would like to congratulate again the organizing committee, the scientific committee, and participants to this Brain Week in Kigali. Rwanda is committed to continue to work on policies, research, clinical practice initiatives, advancing brain health in the country and in the region. On behalf of the Minister of Health, I commend the organizers, partners, participants for your commitment. I wish you an enjoyable and fruitful 4th Brain Week in Kigali. May this week inspire lasting partnership, impactful research, and concrete action that improves lives beyond this conference. And with these few remarks, and on behalf of the Minister of Health, I declare open this 4th Africa Mena Brain Week in Rwanda. Thank you.
Thank you very much, Dr. Gishoma, for officially launching this important week and for the continued support from the Ministry of Health as well as Rwanda Biomedical Center. And we're grateful for such support. A round of applause to them. Now we transition into our first keynote lecture, a very exciting moment. We are here to learn about brain health, mental well-being, and so much more. So brain health forms the foundation of learning, behavior, resilience, and overall quality of life. It is my pleasure to invite Professor Abdallah Shehu, an expert neurologist from the United Kingdom, to deliver his keynote lecture, Brain Health and Neuroscience. Round of applause.
Are the slides ready? The slides, please. Thank you. Is this a pointer? Right, Bismillah ar-Rahman ar-Rahim. Hello? Hello? Can you hear me? Hello? Can we sit? All right, good. Bismillah ar-Rahman ar-Rahim. My dear distinguished guests, Professor Darius, representative of the Health Minister in Rwanda, the Chancellor of MSUT, and the Vice Chancellor, representatives from the university, my colleagues from the Mena Brain Week team, important guests, ladies and gentlemen, I greet you with Assalamu alaikum wa rahmatullahi ta'ala barakatuh and say good morning and welcome to the Brain Week. Now, my task is to be talking about brain health and neurosciences. And really, I'm really pleased and encouraged to hear the wisdom words of Professor Darius, who concluded my talk in terms of what I will be advising the government of Rwanda to do and the governments in Africa to do. So he's already taken that advice. He's already got a lot of information from this talk. So that's actually a lot of the work done. The other part of it is for all of you guys, everybody to think of what they can do to make brain health a priority in their lives and what message we take to those who have not been fortunate to attend the conference today. Hello? I'm trying to move the slides. Thank you. Hello? Can we have it on both sides? No? Thank you. Now, brain health, as has already been mentioned, is a state of brain function across the entire function of the brain, which is to do with the mental side, i.e. the cognitive side, ability to remember, the senses that we have got given to us, all the 7 senses that we have, our social, emotional, and behavioral as well as motor function. So it's not only the absence of disease that defines brain health, all of these have to function in allowing a person to realize their full potential over the life course from birth to death, however long the life might be. In addition to that, we have to remember the brain is not only about the brain health, but also there's mental health, because we neurologists deal with the brain health, the psychiatrists and psychologists deal with the mental health aspect of it, and that mental health has been defined by the World Health Organization as a state of mental well-being that enables people to cope with the stresses of life, restore and realize their abilities, and work well and contribute to their community. So in a sense, we cannot function properly, and nobody will function properly without a good brain function, both the physical side of the brain function and the mental side as well. The next question is, what is neurosciences? Neurosciences does not start with the diseases. It starts actually with the anatomy. with the physiology, with how we've been made up and created by God, the Almighty, who created us. And that means it starts from the cells of the nervous system, the cells of the body that are governed by the nervous system, and includes how we behave, how we interact, how we function, and then to our co-function as we live in our lives, and also dictate the policy that we live through our governments and every effort we make. So this is what is affected by the definition of neurosciences. Now, what is the, sorry, am I going forward or backwards? It's going in either direction when I press it. Can somebody help? Whichever way I press it, it moves in the same direction. Or the bottom one. Should be backwards. Does that work? Does that work? Thank you. Thank you. And the top one is forward? Okay. So, global health. The global burden of brain disorders is something that we should realize is very, very important to us. And why is it important? Because it is actually the worst thing that can happen to anybody, in the sense that it is the leading cause of disability worldwide. This, as we can see, includes the major diseases that we've already had mentioned, whether it's stroke, epilepsy, dementia, mental illness, and these have major economic and policy weight that they bear on the community as such, in addition to the social impact. Why does it matter? Because they affect all ages. We have babies born with brain disorders. We have people dying of brain diseases, whether it's dementia or stroke or other neurological disabilities. That's what the causes of death can be due to. We have seen how brain health damages community, because if you have a disability, whether you are an infant, that puts strains on the family. And and also if you have disability, it stops you being able to work and function as a human being, and therefore affects your ability to be productive to the society. Brain health is developmental and an economic issue. So because it can make a family or an individual to be poor because of inability to function properly from the disease. As Professor Darius mentioned, there are over 3 billion people worldwide with neurological diseases. Now that's about 43% of the global population. Now there is nothing bigger than this, and nothing is a bigger threat than this. And if we can see that about 440 million people have strong disability from neurological diseases, that's a huge burden. With 11 million people death annually. Now this does not include those who die of accidents and other things, which obviously may be resultant into brain damage. So it's a leading cause of disability worldwide, and it has been seeing an increase in the burden since 1990, probably because we live in a bit longer. And as we can see, from 1990 to 2020, this is when this surge of increase in the number of mortality and morbidity from brain disease has occurred. As Professor Darius mentioned, about 1/3 of the population are affected, leading cause of illness and disability worldwide. We can imagine all the diseases mentioned there and how relevant they are to common people, and whether rich or poor, it does not matter. These diseases affect people and they can be very seriously damaging. The mental health aspect of it is an additional problem affecting 1 in 7 people. And I'm sure this is probably even an underestimation, because many of these people who have got chronic diseases have got mental health issues related to that as well. In addition to that, other stresses of life obviously can happen, and the stress that is caused on the family who have a loved one with neurological disability can equally cause mental health issue in them. So stroke is leading, unfortunately, but somehow is fortunate. And the reason I say it's fortunate is because it's one of the causes of death and disability that is somewhat modifiable. And I'll talk about it very briefly in the next few slides. We have migraine, which can be disabling in terms of employment and other things, but then dementia is rising as we get older population, and epilepsy is a big problem. And big problem, especially in Africa, where we do not treat it very well because of lack of medical resources and everything else. So this just to indicate how things, including infection of HIV and other diseases, chronic, that can actually affect the brain function and cause disability and affect the society at large. And I don't need to go through all the diseases here, but you can see even the common diseases such as hypertension, diabetes, obesity, in addition to the infections, all add to the problems. How many people smoke in a society? How many people are affected by alcohol in the society? How many people are not active, not influenced, not physically active for one reason or another? It's all part of the mental health issues and physical brain disease that can affect people. Why is Africa a bigger problem? Because the low to medium income countries carry a majority of the burden. The sub-Saharan African has high disability rate, and stroke remain the dominant contributor to this if we take away trauma from the effect of war and other challenges that we have as Africans. A typical example of an African sort of cohort indicates that morbidity of up to 350 out of 1,000 outpatient attendance is due to neurological disorders. That's just over 1/3, and it's really, really significant and cannot be ignored. We have common diseases such as headache, stroke, epilepsy that present in addition to the chronic ones such as Parkinson's and other spinal disorders. This does not include the pediatric cohort because there are children born of neurological diseases, children with epilepsy and so on. I remember there was a time I was in Nigeria. Hello? There was a time I was in Nigeria 2 years ago, and I went to the medical ward. And on the medical ward, I was informed that about 50% of the inpatient admissions on the medical ward is all due to stroke. And that's a major problem for all of us. The neurological burden also includes, as I said, the infections, the HIV, and the untreated conditions. But we have to be aware of the perinatal and nutritional causes of neurological diseases as well. These are part of what we say can be prevented, and trauma and road traffic accidents can also be prevented. In fact, I must commend the government of Rwanda. One of the things that really caught my eyes as soon as I came out of the airport was seeing that every motorcyclist is wearing a helmet, including the passengers. So really, really, this is encouraging. You don't see that in many African countries, and this is an excellent leadership, an excellent way to protect the brain. I just hope everybody wears it properly, tightly, so that it does the job, so that when they have accidents, it doesn't fall off and leave the head to be stitched. Thank you. We've already had the diseases that cause the problem, stroke being the highest, and we have the dementia and everything else. But what we cannot ignore here is encephalopathies, which are infections that affect children in early childhood, or diseases that affect children at birth, leading to cerebral palsy, leading to other things that may remain permanent in a child. And I'm sure the pediatricians here and those who deal with children can actually understand that. The other aspect is neurological complication of systemic disorders. What I mean by this, for those who are not doctors, is that many people may have diseases such as diabetes or hypertension or other disorders affecting cancers and things like that. They all can affect the neurological condition, and people with cancer may not die of the lung cancer, but they die of metastasis to the brain because the lung cancer has not been treated early, and that becomes a cause of it. So we have to be careful how we address these other conditions as well, because they impact on the brain health. So here we are, while we come to how the community can look at helping itself, how each individual may have something to consider. We know the young people have an opportunity to prevent diseases among themselves, but also supported by the government infrastructure, of course, which Professor Darius has already mentioned in Rwanda is happening, because you have an excellent primary care system. So, but what is important is the education of the people, and therefore people can look after themselves, preventing head injury, making sure that if they have diseases, they are treated adequately. And hello? Now, so coming to Rwanda specifically, what I thought is, from what I could gather, and please forgive me if my statistics are wrong, but they could not be far off, I understand the population of Rwanda as a country is just under 50 million people, with an average of age of 19 to 20. This is average age. It doesn't mean that's the eldest. I mean, I remember in Coventry, where I come from in England, the average age there is 33. The reason is 33 is because we have many migrant population and other people and increased birth rate in some of the communities that drops the age that down. So it can be due to many factors. But your effect also is because of the consequences of the genocide and everything else that is still gradually being replaced by what normal communities normally feel. But this gives an opportunity for Rwanda to do what it has already been doing and to excel in something better for the future. Is the reason why you have a very strong primary healthcare system. You have community-based health insurance and digital health innovations that are helping and shaping the future of healthcare in this country. So there's a clear national vision for development, and I hope that development will now include, not only include, but prioritize the provision of brain health and mental health as the most important factors to address, because that's what the statistics tell us. It is a life coach approach, so we cannot dissociate any aspect of our life from brain disease. It is continued from childhood through to adulthood and aging, and early investment brings lifelong benefits. We have to think on how we invest in the young mothers getting pregnant, the child they give birth to, the circumstances that child is born to, how they looked after, and gradually preventing those diseases that we will come to know. So from pre-birth to old age is our challenge that we have to make sure we deliver on. So good nutrition to a young mother and to a family will also have impact on the health of the baby that she will give birth to in months to come. So replacement of deficiencies, whether it's iodine, iron, folate, and proper food, nutrition, protein, everything else, really will be very good. Preventing infection, immunization programs and things like that. Avoiding things that can be avoided, but can only happen through education. Early stimulation and education for the children and also the mothers, and safe childbirth. We have to make sure that every woman who is going to give birth has got a circumstance that will allow her to deliver the child safely, reduce perinatal sort of complications that can affect the child brain health and cause permanent damage. Policy implications is highest return on investment. You invest, the government invests at this stage, the benefit will be reaped in a few years to come, and this will bring the society to be even healthier. What about the adolescents and the young adults? This is a big challenge for us because the mental health challenges are also affected by the behavior of the individuals in question. Risk of substance abuse, head injury, stress and sleep deprivation, difficulties in facing life and things like that. These are all the mental health issues that can bring on together. Relying on alcohol and drugs to shape our future, thinking that the recreation we have for that moment is enough to make us feel better while we forget the future, is the kind of message we need to be sending. And this can only happen through education right in the early stage, from the nursery to the primary school to the secondary school, about the implications of these habits, but also creating alternatives for these children so they don't have the boredom to take them back to these events. And safety sports can also be included here, and of course community engagement. For the adult, it's a different picture because we know the diseases, some of which are that we can't control the onset of. We don't know. Some may have a genetic predisposition to have high blood pressure or diabetes or other conditions. We can't change that, but we can change how the disease is understood and affect us for the future. We can try to make ourselves not obese by our diet alone. And I don't mean, there are some people who are overweight because that's how they're genetically made up, and they can starve themselves to whatever level, they will not lose weight. I'm not talking about them. They are fit as fiddle and they can live to their old age. It's not a problem. But those of us who are artificially overweight can actually influence it, and we're the ones most affected by this. Smoking is something that we know is bad, but it's advertised everywhere in the world, and young people are buying into it, and we think it's a way to recreate, but it's also a way to harm ourselves. Not mention only about the brain disease, but the heart disease, the cancers, and everything it brings. We have to encourage physical activity in the young people because sedentary lifestyle is a killer, both with regards to brain and also the heart. And which says that whatever is good for the heart is good for the brain. Stroke, as I mentioned earlier, is a preventable disaster because it's common and we can do something about it. If 80% of the causes of stroke are modifiable, nobody can say to me, we can't do anything about it. I'm sure we can, and we just need the effort as individuals, as community, as a government to actually do something different. And we can influence the cause of stroke, and we can do something about it now, because time is brain. This is just how it shows that the statistics here is slightly skewed, because we're not talking of Rwanda or Africa. That's why epilepsy is even lower than dementia. If we're going to look at statistics in Africa, it will be the other way around. For epilepsy, will be much higher than dementia, because it's a young population, and epilepsy will be much more prevalent than that. Dementia affects the elderly, and this is just talking about neurodegenerative disorders as a whole. Education is important. Some may be able to prevent it, some may not be able to prevent it, but we can actually be certain of one thing. If we maintain a very good blood flow to the brain, we reduce the most likely provocative factor of dementia, which is vascular damage to the brain. Whether you have Alzheimer's disease or vascular dementia, circulation to the brain is important precursor to the development and progression of dementia in this age group. So we have to do something about it. Social engagement. Isolation is very difficult. If you have people who are isolated, they live alone because they've lost all their loved ones, make sure the community engages with them, because they become more forgetful, they become more risk averse, they become more unable to look after themselves, disinterested, depressed, and then more things happen. People who have impaired hearing and vision care also need to be provided for. So mental health is brain, and it's brain health as well, because it affects productivity in families, it impacts on physical health outcomes, and integration into primary care is essential. So the message here for everybody is that mental health has to be addressed right from the beginning. If we look at some individual conditions that I want to highlight, epilepsy, for example, is a condition that is very, very common in Africa, and we had is one of the leading killers, one of the leading causes of disability in Rwanda, but it has many other factors associated to it that I'm sure we will discuss during the course of the program. Now, many of the causes are preventable, some are not. Trauma can be preventable. Some people developing infection in the brain may be preventable, but may not once the infection has settled, and so on and so forth. But what is killing people more is lack of treatment and lack of awareness that they have epilepsy. If somebody does not have treatment for epilepsy, their risk of dying is very high. We have what we call sudden unexpected death in epilepsy, which can be very common. Following is just somebody just dies. But what is killing people a lot more in African countries, including Rwanda, is a strong taboo around that. And I'll mention this very, very strongly, because the taboo puts people in a very bad vicious cycle. Once I know that if I'm diagnosed with epilepsy, nobody will give me a job, nobody will marry me, nobody will look at me, nobody will give me anything to work with, I'm isolated. What do I do then? I'm just waiting for death because the community has rejected me. And that's not the attitude we should have towards any illness, because nobody is exempted from having any of these diseases. And I hope we all remember that. So epilepsy burden in our countries, as I mentioned, is very high. And the role of nurses and allied professionals and individuals is, please, nurses and allied professionals, community health workers, they need to be trained. They need to go out in the communities, because not everywhere has doctors. Not all doctors are neurologists or psychiatrists or whatever. So it's important everybody gets educated about these diseases and they can signpost them. And people need to be empowered on how to manage the first crisis and how to escalate the issue so that somebody gets treatment and advice, and make sure that drugs are available and patients have access to them, either free, or if they're affordable, then at least, I don't know what the healthcare system, if everybody is getting free or not. But this is something that has to be considered. What is also lacking is rehabilitation. There is no information on how people who have a stroke are being managed. The moment they are discharged from hospital, they are left to look after themselves at home by the family. And most of these patients end up with pressure sores, infection, and then die from it. Or they die of malnutrition, or they die of something else that is preventable. So we please have to make sure we prevent that. Community trust is important, and this is something that the health and allied professionals need to make sure they build in their system. Because if you're trusted by the community to deliver, you become the first port of call when there is a crisis, and you can escalate it then. What is the role of the patient in the family? This, we know, has impact on their dignity and independence. We mentioned how the taboo judges against people with epilepsy, and this is something that the family and the community have to try and fight against. And I hope it's an educational program that one can lead for the future to make sure that this is prevented. Everybody needs to be respected, and that respect, whatever, needs to come through information, understanding that these diseases are spread all over the world, and people with these diseases are leading a perfectly normal, healthy life in many other countries because they have received the right treatment. They have to be included in decisions. They cannot be sidelined. When patient's decision is being made by the health professional, it's not always nice when you're just told to lie on the table, have an operation, and you're not prepared mentally why you're having the operation in the first place. We have the effect of technology and innovation that is helping shape the future. We have teleneurology, and I'm sure we'll hear about it sometime to talk. We have the role of artificial intelligence. We have mobile health apps and digital education platforms that we can use, and very much low-cost innovations that can eventually lead to the higher cost, because once the economy is evolving and developing in the future, then the rest becomes much more easy. Therefore, we have to look at how the evidence had led to policy decision. And I'm really pleased to hear that in Rwanda, they're already taking the lead. The preventative aspect is being discussed. They're investing in that prevention and supporting the workforce training, and more specifically trying to even encourage neurological training in the country and more things started to develop. That this cannot be done without strengthening the data, because data is information. And this is the role of the other healthcare professionals, the nurses, the allied things that go out to the communities. They need to be armed with collection of data that they can bring, and the federal government looks at how to do it. Schools and other organizations all need to be involved. Training of doctors, nurses, and healthcare workers. Task shifting work will need to happen, everybody escalating to the next level, and regional centers of excellence need to be decided. I'm aware that Rwanda is a small population, but if Rwanda excels in an area of neurosciences to develop a good center here, it can be the regional center for the neighboring countries, I'm sure of that. And it will be another source of development and income for the country, which also puts it geographically and politically in the very best position. We have access and thinking of research and local data, as I mentioned before. This is very essential that we can't rely on imported data from outside. We have to have proper African data and specific countries data that will be ethical and also inclusive neurosciences provision. So I say brain health and mental health is everybody's business. Whether you're working in the health sector, whether you're working in the educational sector, or even you are involved in transportation and safety, because there are many diseases you can prevent. The environmentalists who are working in the ministries of environment, the tree plantation and everything else, they're all involved in mental health. Provision of good water supply, provision of sanitation removes all the communicable diseases that eventually affect the brain and social sense. But also, we cannot ignore the social policy. That social policy has to be embedded in the culture of people to make sure that nobody is isolated. In the neighborhood watch, the responsibility of the community, whether it's in mosques, in the churches, in the other faith centers, they have to make sure other people are engaged. And then the government provides the atmosphere and support for this. I think I've already covered this slide in the sense that of what the advice for the government will be, and Dr. Darius has already hinted to them, so I don't need to go into that. But really important that the targeted HIV clinic integration, we can have an HIV clinic and other chronic systemic diseases like diabetes clinic and things like that, looking at how can we be preventing neurological complications of these diseases at the same time. So if the HIV specialist or those who are looking after them in the community, whether they are community health workers, they can actually be saying, I need to make sure this patient does not end up with neurological complication of HIV. We need to have a school policy that will make sure people are educated about health issues in the future. So the strengthened data system, if we want the policy to work, expand the workforce training. We have to improve access to diagnostics and availability of drugs. We have to have a community education, public campaign, media campaign, every way we can do it, using social media, but they need to be seen and to be heard and be able to answer questions. These are the only ways we can prevent taboos influencing us and making us have a lot more people with mental health issues. If we can prevent and develop method that we can make sure that everybody who has hypertension is detected early and treated, people with diabetes are detected early and treated, people with infection are detected early and treated, road safety is improved, believe me, we can change mental health future in very, very short time, because these are the kind of things. So given some statistics to say that, we have heard earlier on, epilepsy prevalence is very high, much higher, a little bit higher in women than it is in men in Rwanda, but actually that's a very significant number, okay? And then we have 3% of the population having HIV, again slightly higher in women. And look at the death in stroke, almost 9 to 10% of patients with stroke die from it. Now this is a population we already said is a young population. So how come we are not able to prevent stroke killing our young people? Because we're not managing the risk factors properly. Every individual needs to do their best to manage the risk factors so that the stroke can be prevented, and then the government will do its best to provide the infrastructure that will set up the facilities for treatment of stroke immediately to save life, and then rehabilitation to make sure they have the benefit of improving. We also mentioned the effect of mental health and trauma, and we know that 20% of the people are affected, but this is even more than twice affected by those who have witnessed a genocide. And so this is a very, very high number. We need to have mass campaign, mass publicity, mass education, mass sort of inductions and support, train psychologists, train other people so they can help the mental health and well-being of the society. And if we do that, people become more productive, okay? We do have shortage of neurologists, I acknowledge that, and you don't manufacture them in a short while, but this is a vision that can be set in place, and the government, I'm sure, will take forward that. We have poor data and surveillance that can be improved. We have limited diagnostics that I'm pleased will improve significantly. And just earlier on, we're talking here at the university about how the laboratories here can help develop some of the facilities they have to actually provide for the community and beyond in order to continue to increase the availability of access for everybody. If we can reduce stigma and improve awareness of diseases, we can achieve a lot. Poverty and mental health are going in a vicious cycle, because with poverty, we have lack of education because they can't afford it. That then leads to unemployment. And if that person becomes ill, which now becomes very easy because they are susceptible to infection, they are malnourished, they're this and that, whatever, then that even makes it worse. On top of which, you then add a taboo that they become society isolated. So unless they are simply required to go and commit suicide, I think they have reached the end of their tether. We have to rescue them from that situation, break this vicious cycle, and try to see what we can do as a community, as scientists, as clinicians, as policymakers, so that we can make things better for the future and the mental health can improve. So the brain health should actually drive national development. And for all the obvious reasons I mentioned, and I'm sure everybody here buys that, not only the government, because Professor Darius already mentioned that. So this is something that has to be driving the national agenda if health is going to be maintained, because brain health disorders are preventable. Majority of them are not curable, and once they set in, the disability becomes difficult to manage. So we have to worry about prevention, which is cheaper and more effective. The systems matter more than the technology. We invest in the prevention. The affordability of the technology can come gradually because we then have more better workforce in the community that can raise the money, make the economy more viable, more investment from other countries, and then we have all the technology can throw at us in order to make diagnosis better. I'm trying to conclude to say that neurological disorders are a major global challenge, but in Africa, they're a disproportionate burden for everybody. We have to have a coordinated health system and policy action that can actually bring everything together. We have to have people and leaders that can see the future and focus on what is going to be happen to the society beyond their time. In 20 years' time, 30 years' time, 50 years' time, what is going to happen? How do we shape it today? That is the way we need to look at, because the solution lies in our hands. When you think brain, when you think health, please think brain, act early, and we work together. Thank you very much.
Another round of applause to Professor Abdallah Shehu from that very insightful lecture on how the brain works, the disorders, and how we can be able to deal with that. So I'm sure you've been seated for quite a bit. So we want to take some group photos before we proceed into the second lecture. So I'll ask the team to come and remove this lantern. So we'll start off with the honorable speakers, the guest of honors, to be in the front, and everyone else seated, you can join, but in the back. So for now, you could be standing and move a bit, move your feet, your arms, and have some movements so that we can get ready for the next session. But we could also come to the front, those in the front seats for a group picture, and the ones in the back to join in as well. The speakers, professors, the chancellor as well. Yes. The photographers can direct them so they can.
So nobody said speaker number.
Main speakers and then
Sorry? The speakers, the next speaker, there's one in the partners in health who's going to be the lady. She needs to be next because she's got something to go to. So make sure.
Hello? Can please let the main speakers be on the first stairs, then the rest you can stand behind them. Can we do it as quick as we can?
everyone else, please join the group photo at the back. We would love to have you part of this momentous occasion. So just step at the back for a group picture. Everyone in the room, yes, everyone, that includes you. Those seated, please join the group picture. We can have some background music. Yes, squeeze in, squeeze in. Yes, don't be afraid to go at the back. The cameras are going to capture each and every face. Smile. Say cheese. Happy faces. Yes, happy Brain Week. Let's go. Yes. Wave to the people. Thank you, everyone. Thank you, thank you, thank you. Thank you for your cooperation. We have a couple more lectures to go through, very exciting, very knowledgeable, so get your ears and minds ready. So we have Nadine. Can someone help with the lantern? Excuse me. Yeah, but they told me that they want.
Not stop presentation because each time stopping.
Yes.
Hello, hello.
Okay.
So, like I said, we would like to now heading over to the next keynote lecture. Integrating mental health into broader health systems is also very essential for holistic care. So I now invite Ms. Nadine Karima, Country Director of Partners in Health, Rwanda, to deliver a keynote lecture. A round of applause to her as we welcome her. Thank you very much.
Thank you. Dear organizers, dear Dr. Gishoma, representing the Ministry of Health in Rwanda, dear Professor Najib, all protocols observed. Thank you for having us. I would like to present some of the work that we've done as partners in health around the world, and then zoom into the work that we've done in Rwanda in collaboration with the Ministry of Health, represented here by Dr. Gishoma, sorry. Next. I have the clicker. A little bit about the organization that I represent, Partners in Health. We work in 11 countries. We were founded in 1987 with the aim or the goal of providing preferential care to the most vulnerable in the most remote areas of the world. We go from building hospital to providing medicine to providing socioeconomic support, all in collaboration with the governments that invite us, so that we strengthen the local systems. And we hire local staff, and we make sure that we walk along our partners through a model that we call accompaniment and through pragmatic solidarity. A little bit about PIH mental care and neurological care. We make sure that we have a model that is evidence-based and can be expanded globally. And it's a model that we embraced based on the needs from the previous speakers. You've seen that there are high needs for mental health, for brain health, for integrated health. And I want to appreciate the previous speakers, Professor Abdullah and Dr. Darius, for setting the stage around integrated care. So our models at Partners in Health involve community-based care, task shifting or task sharing with frontline providers, so non-specialists, and integrating the care into the primary healthcare system closer to the patient. All of our PIH or Partners in Health mental health teams across the world have this model of making sure that we focus on scale up, we focus on evidence, and we make sure that all the interventions are integrated into the public system. And our mental health clinics treat not only epilepsy, but also depression, anxiety, trauma, psychosis. Why? Because we, as an organization, believe that mental health, or all health, are human rights. And we believe that it all starts with brain health and mental health. So as far as Rwanda goes, we have the mentorship enhanced supervision model, which I'm happy Professor mentioned, which means task sharing with health centers or the local clinics, and ensuring that providers at the local clinics are trained, non-specialist providers are trained to assess and to manage the basic symptoms of brain health. We also make sure that we train the community health workers at the village level so that they can assess or they can detect at least sign of neurological health disorders or other brain health disorders, and refer appropriately to the clinic. So far, epilepsy cases represent 29% of the cases, or I would say 30% of the cases that we receive in our mental health clinic. So a third, which again, based on the previous speakers, show that there's a high need for epilepsy care. In Sierra Leone, where we work, because we do work in 5 African countries, so South to South Connect is also part of what we do. In Sierra Leone, in West Africa, where we work, we have community and clinic-based mental health services that started since 2019, and we do have a psychiatric residency program. In Liberia, also in West Africa, we transition from facility-based to community-based care for mainly epilepsy along other mental health care. And finally, in Malawi, we have an integrated clinic that integrates HIV care, NCD care, and includes epilepsy and mental health disease. So this integration has been key to reduce any stigma and to make sure that more providers are trained on managing brain health. Zooming into Partners in Health in Rwanda, we are locally known as Inshuti mu Buzima, which is the Kinyarwanda translation of Partners in Health. And that's a method that we use in all the countries where we work. We make sure that Partners in Health is translated in the local language. We've been working in Rwanda since 2005 upon the invitation of the government of Rwanda, and our mandate has been to support the transformation of the health system and provide care or model the care that we had started with in Haiti in terms of community-based care and involving the community and psychosocial rehabilitation of patients and apply that into HIV care in Rwanda. Currently, we work in 3 districts. Rwanda has 30 districts, so we work in 1/10 of the district. In Rwanda, our approach has been driven through strong collaboration with the Ministry of Health and the Rwanda Biomedical Center. We started mental health care in 2009 in the northern province in a district called Burera with 1 psychologist, and we developed a community-based model of care. And now that model has been implemented in more clinics, in 19 going into 25 health centers and hospitals. In 2012, with the Ministry of Health, we make sure that we implement a structured mentorship program called MESH. It's Mentorship Enhanced Supervision Model to enable nurses to treat patients with 4 neuropsychiatric disorders. And now the model has even expanded to involving the local leaders, local influencers, to make sure that stigma is reduced as much as possible, and that patients, after they've sought treatment, are reintegrated into the daily life of the community. As most of you know, in Africa, if you're not part of the community, you're nothing. Okay? So psychosocial reintegration has been very key to the approach that we have. And in 2017 to 2018, the model was expanded to 2 more districts of Rwanda in the eastern province. How does our model look like? From the community level, we do a lot of awareness to reduce stigma, to make sure that symptoms or signs are detected as fast as possible. And we use the first frontline care providers of Rwanda, who are called the community health workers. Then at the health center, which is the next level of care, or called in some countries the clinic, we make sure that the nurses are capacitated to handle not only mental health, but also chronic care, and to screen neurological and mental health signs. And part of the job of the nurses is also to make sure that beyond case management, they do follow-up and home visits, and that they coordinate through the social worker for the social reintegration of the patients. And finally, at the district hospital, which is the higher level of care in a district, we make sure that we have specialized mental health services. For example, we were the first district hospital to have an EEG machine to treat, or at least to do further diagnostic of the patients. We make sure that there's clinical mentorship from the nurses at the district hospital going to the health centers and connecting with the community health workers, especially when you want to track patients and you want to ensure that they're not lost to follow-up. And finally, quality health improvement project. Through that, we have enrolled so far about 18,000 mental health patients only in the 3 districts. And of course, 6,000 of them or about are epilepsy patients. Our model is evidence-based. Working with the Ministry of Health, we make sure that epilepsy was integrated into the MESH, Mentorship Enhanced Supervision model of mental health. Within only 2 years of starting the model, we had 286 epilepsy patients who came to seek care and 3,307 visits, which demonstrate that it is feasible to treat epilepsy at a lower level of care. We were the first rural clinics to implement this model, and now it's been scaled up nationally. What have we learned? We learned that patients with epilepsy reported less seizures after 1 year of integrated care. Why? Because we had a holistic approach. We had more follow-up, and we also worked not only on reducing stigma in the community, but also reintegrated them into the community. We also learned that multi-disease integration can improve neurological outcomes because the patients don't feel alone. They feel like they're just like any other patient going to seek care. We also learned that task shifting or task sharing, however you might call it, can improve clinical delivery. And we also learned that treatment for epilepsy, for brain health, can be delivered by primary healthcare nurses as long as you train them to assess, detect, counsel, and refer when it's really needed. So what are our future plans in Rwanda around brain health? We want to expand specialized care. There is a misconception that primary health care should be just low-level based specialization. It's okay to integrate them into primary health care. We want to make sure that we strengthen community engagement to reduce stigma and to enhance the reintegration of patients into their community after they finish their treatment. We want to leverage the new community of health model that is championed by the government of Rwanda, which has what we call a polyvalent community health worker, a community health worker who can treat most of the prevalent diseases. And lastly, as part of our theory of change at Partners in Health of caring for the patient, training providers, advocating for policy changes, and replicating the lessons learned through further education, we want to make sure that through the Partners in Health University, the University of Global Health Equity, we not only have a clerkship program that is linked with the University of Rwanda, represented by Professor Stefan, and Ndera Hospital, but also now we would like to launch in few months, and you'll hear about it, a residency program around mental health care. So our first cohort of medical doctors graduated 2 weeks ago. Some of them want to be psychiatrists and fill the gap that we have around psychiatry, and why not be neuropsychiatrists so that we can have more in the country. And that will only be possible, of course, if as partners we collaborate, we continue the South-to-South collaboration and mentor the young generation so that care is more accessible to the people that we care for. These are a few references about our studies and research projects that I've shown that brain health, mental health care, mental well-being are possible in a rural, resource-limited constraint as long as you train the people and you also invest in community awareness and stigma reduction. With that, I would like to thank you. And one of the speakers mentioned that it's not just about research, treatment, doctors, but it's about the patient. And at Partners in Health, everything that we do is for and about the patient. We call the patient our boss, and I would like to share a video of one of our patients. Thank you. It's a very short video, and while the technicians are getting ready for it, I would like to thank our patient, which we actually call our partner, Claudine, who's in the room. Claudine is a rural-based patient. She suffered from epilepsy, and in one of the episodes she had, she fell on a fire and got burned. But through the treatments and the psychosocial rehabilitation, she's regained her confidence. Now she's a thriving mother. And of course, she's been accompanied by her mother, Mama Claudine, who's been the main pillar of support. And Claudine is now a businesswoman and an artist. Mama Claudine, murakoze cyane. Video, please. Just a snippet, and in a few days you'll hear more about Claudine's full journey. Could we have some sound? This is Claudine after her treatment. And for the ladies in the
ibyumviro
room,
dufite
right?
Korodina ubu ngubu urabona umwuga Partners yamushyizemo kwiga gukora imigongo, mbona yarabimenye. Birashoboka n'ishuri ribonetse yagenda kwiga. Ubu icyo ariho ni ukujya kwiga, ni ukujya kuri Partners. Niyo mutamuha ibyo akora we yaza akahicara akaba azi ko ari mu bantu bamukunda kandi bamukurikirana.
Nuko rero nzaba nambaye agatimba ndi kugenda birere. Intego mfite muri jewe nuko niga nakiga neza, nazasohoka nkagenda mbikora neza, nereka n'abandi. Nshobora nko gufata nk'inzu nkayubaka, ashyiramo ibiro byanjye nzajya ncururizamo, nko kwiteza imbere. Mvuga nti ishuri sohotse ngiri, bagenzi banjye batabizi bari hanze aha batabizi, nkaba nanjye najya mbabwira nti muze mbigishe nta kibazo, nkabigisha tukagenda twiteza imbere gutyo. Kuko ndi kumwe nawe kandi sinshobora kugutererana. Wakubishije ko
Inshuti mu buzima itihanganiye ubu burwayi ntago ibintu byagenda neza, ariko ngeretseho no kubashimira. Inshuti mu buzima irakora, iritanga, ikitangira abantu mu gihe ubona wowe bidashoboka.
ariko nyine urihangana, aririmbireho gakeya. Turanezerewe, Yesu wabikoze turanezerewe, ibintu byiza
Thank you.
Thank you very much, Ms. Nadine, for that presentation about Partners in Health, what they're doing for the community, as well as that beautiful testimony from Claudine. Now, moving ahead, we'll listen to our next keynote speaker, Professor Rachid Souleimani, all the way from France. A round of applause.
Thank you very much. I am sorry, but I don't present my conference by French because I like more French, but just I am more comfortable with French language. But as you can to see in my slide, you have by yellow colors English presentation and in black colors French presentation. It will be very easy to understand my presentation. I just want to thank my friends, Najib, Chantal, Professor Abdallah, Tanguy, and some colleagues who had worked hard to success this congress, because we began this congress with Najib in 1999 in Morocco, when we want to confront scientific research by clinical research. We began this adventure. I just this subject is very sensitive, because impact of early exposure to environmental and dietary contaminant and neurodevelopment. This is a challenge for cognitive and for social development for the South country, for the country of the South. Je vais continuer par le français. In yellow you have English and in white you have French. Quelques données sanitaires sur l'épidémiologie. Sur l'épidémiologie, nous avons autour de 28 maladies en Afrique qui sont directement liées aux risques environnementaux. Et il y a des problèmes qui sont liés à ces maladies comme la diarrhée, les infections respiratoires, le paludisme sont les maladies les plus fréquemment citées. Mais attention, l'Afrique est en train de connaître une importante émergence des pathologies neurodégénératives. Si on regarde pourquoi l'Afrique connaît ce problème, parce que tout simplement, il y a une fragilité, il y a une vulnérabilité avec le changement climatique, et il y a aussi une carence en sécurité sanitaire. Et ça va contribuer à l'augmentation de la prévalence des maladies à transmission vectorielle. Donc vous allez avoir tout simplement une émergence des pathologies neurologiques en cours de devenir très importante, et on est en train de connaître également certaines données issues de la recherche internationale qui montrent très bien que les causes environnementales sont très très importantes, puisqu'ils vont déterminer certains facteurs comme la sécheresse, la poussière, l'humidité, comme le changement climatique, comme la trépanosome humaine, africaine, comme l'indiquent les chiffres, 65 millions de personnes dans 36 pays endémiques sont affectés et connaissent ce problème. Alors, le paludisme, n'en parlons pas, c'est un facteur qui aussi intervient dans les conséquences de l'exposition environnementale et qui va être responsable de nombreux décès. Les maladies neurodégénératives en Afrique sont surtout la démence et le vieillissement cérébral, le konzo qui est provoqué par la consommation du manioc contaminé au cyanure. Il y a également l'épilepsie et les troubles mentaux my colleague Professor Abdullah, I remercie him because to introduce my conference with any informations. Si vous regardez le tableau, vous voyez impact on the brain. C'est important parce que il y a l'altération cognitive, la démence, il y a également la neurotoxicité, il y a le stress, la malnutrition, et tous ces éléments sont documentés au Lagos, au Caire, au Kinshasa, il y a également en République démocratique du Congo, l'Afrique du Sud. Vous avez, ces données sont récentes et indiquent vraiment qu'il y a un vrai problème à prendre en compte en Afrique. Sinon, ça va évoluer vers une situation qui sera très difficilement maîtrisable. Alors, si vous regardez, tous ces liens vous permettent d'avoir toutes les informations. Alors, si vous regardez l'impact des facteurs environnementaux, ils sont répertoriés. Il y a plein de recherches qui ont été faites. Alors maintenant, la question, cette contamination chimique de notre environnement qui n'est pas souhaitée et qui n'est pas évitée, est-ce qu'elle présente un danger? Est-ce que there is a danger and health risk following this environmental exposure? Lorsque on veut étudier ça, on va devoir, je m'adresse aux scientifiques, I speak with scientific researcher, medical doctor or other, because we have defined some criteria to release some experiment works about this neurotoxicity effect in lab and in clinical study. Le problème, what is the problem, is chronic exposure. This is a problem because when we have exposure 1, 2, 3 times is no problem. When we have exposure chronically is a problem. Second criteria, this is low doses, exposure to low doses, because low doses is a regulatory limit, is defined by regulatory agency to not use or to be exposure more than this doses. But when we are exposure in these doses, we have a risk. What third criteria to chemical cocktail? There is nobody which exposure to one chemical. It's not possible. We had exposure to cocktail of chemical compounds. We must to consider this in our research work. And the third, this developmental, neurodevelopmental phases is very, very important because it's very sensitive period of development. And in the final criteria, neurodevelopment is more sensitive period of exposure because the brain is more sensitive to low doses of chemical contamination. How to establish this link between exposure and health impact? Because medical doctor said there is some observation, but how to show? We know that we suppose that this link is possible, but we don't have tools to show that this link is confirmed. We have to confirm this. And to answer this question, we require carrying out observation and experimental studies at different levels: epidemiological level, clinical observational level, experimental scientific level. If we work just about one level, it's not sufficient. We have not a possibility to show that this link is realistic. And if we consider epidemiological level, but we begin by epidemiological studies. Professor Abdullah showed that it's important to collect data about epidemiological situation, and to suppose in the human there is maybe impact of this exposure, and maybe to link to pure compounds and mixture contact, what we say now exposure. In the clinical level, we have to explore by clinical study with the group of clinical medical doctor, and to collect some clinical information, and to confront this clinical information with epidemiological information. And in the final, we have to release experimental works from cell exposure to animal exposure, and to project about health effect of chemical contaminant. In the experimental scientific, we must to consider and to collect epidemiological data, and to confirm systemic effect in animals, and to explore in the cells, stem cells or other mechanistic studies. How to create such realistic exposure? We have to work about European program with Horizon 2020, and we have shown about fish, this fish which is in food in some country of Europe, and we have demonstrated, we have shown that this work is similar when we release it under rodent, and to compare this study by human brain. I am sorry, but just to show that in the brain development, neurodevelopment, a period which is very high sensibility is a period during gestation, during pregnancy of we know for conception and prenatal period, organogenesis, and windows of sensitivity of organ in this period is very high because vulnerability and opportunity. We have neonatal period after pregnancy, when mother continue to give lactation period. We have to continue exposure by mother. This is the development of brain and the neurogenesis period in the first of gestation, and you have some phenomenon when we come to see myelination and synaptogenesis, glial proliferation, neuronal disease. This will be cause of some diseases when we became children, adolescent, or adult. This hypothesis, I go speed by our program research, and I work to compare in the rodent and the clinical study in the human, and we have used this animals platform. We have begun our study in start of exposure fertilization, and to continue exposure until end of lactation. And we use very complex protocol to use more than 30 tests in vivo and in vitro and cells to show if there is impact or no. And we please, okay. And we have another biomic neural stem cells platform, and we compile this study between in vivo and in vitro, and we use the stem cells to mime development in utero of woman. And we have, please, this block. Okay, we have shown in this work, European Consortium, that the chemical contaminant in the food impact the neuron and glial cells by to create a disruption of balance, oxidative balance, and inflammatory balance, with the balance to go to pro-inflammatory effect with neurotoxicity effect. And sorry, it's blocked, sorry. Okay, we use the stem cells to, oh no. Okay, this is for chlorpyrifos. This is a pesticide used in Europe and Africa, and the PFAS. This is chemical contaminant. We have shown last time, 3 months before, we have shown that glial cells and the neuron cells will be dead, and we have obtained gliotoxicity and the neurotoxicity by the exposure to stem cells of this pesticide. And for we have studied epigenetic effect, because we have observed that when we stop exposure, the mother in the future generation, we observe that emotional, cognitive, behavior is affected without exposure mother. This is epigenomic study, and this is show we have epigenetic impact by this exposure. We have sorry, we confront, and we had my compilation with our colleague in neurological study between animals, human, and the human stem cells, to be very sure that this exposure is responsible of the effect what we observe. And sorry, I go now. Okay, this is a new concept. This is concept of developmental origin of health disease in adult. When we are adult with Parkinson, with Alzheimer, maybe he was exposed when he is children or before to born. Maybe this is a new concept in the, but we consider in this concept exposure, stress exposure, psychological exposure, xenobiotic, chemical exposure, infection, fetal nutrition. We consider some other factor to speak about environmental exposure. This is our conclusion after 10 years for this study, that sorry. This is irreversible behavioral effect with high anxiety. We can to not reduce anxiety in the generation because this is epigenetic impact in GABA and serotonergic receptors. We have alteration in the development of sensory organ. We have accumulated susceptibility to cognitive decline, and we have decline in memory and learning ability. But we show some mechanistic impact, mechanistic effect by inflammation, by necrosis, by apoptosis, and by inflammatory effect in the neuron and in the glial cells. And what about the socioeconomic impact? We know some study in the world show that environmental chemical contaminant exposure to reduce for 5 to 7 of intelligence quotient in the children, because this quotient, this is the future of each country, because if we decrease the IQ, we have some problem with creativity, with innovativity, with economic development. We have same problem with $6 trillion is estimated for environmental exposure. And you have in Europe same results, and in Africa I look for some data, and in Nigeria, Senegal, we have 1 to 4% of GDP estimated induced by degradation of environment situation. In other country, Ethiopia, Kenya, you have some references for. But what do Professor Abdullah said that we must training for healthcare professional, doctor, dentist, veterinary, researcher, university professor, educator and student, regulate and control. We have some suggestion about this problem in Africa to integrate One Health approaches. It's important because when you affect vegetable, you be affected food chain. When you affect by contamination of animals, you will be look for this in your food, because that's why we have to speak about One Health. And you have some this is general bibliography for this presentation, and this is bibliography of our team. We have 100 publications and more than 30 PhD about this problem. Thank you very much. Sorry for my
Thank you very much to Professor Rashid for that very insightful presentation. Now, we have another presentation coming from Dr. Clarice Musana-Baganwa, who is going to be speaking on trauma, which not only affects individuals, it can leave biological imprints across generations. So it is my honor to call upon Dr. Clarice for her presentation. Is Dr. Clarice with us? She's not available? Oh, okay, so we can head on over to all right, so we have a panel discussion that is going to be taking place in a bit, but before that, we have some microphones that are going to be going around in the audience for people to share some of the things that they have learned through their lectures, just in case you want to say something and give us a bit on insight on some of the things that we have been able to learn from our lecturers. The floor is yours. You could just raise your hand if you want a microphone, and you could be able to say a word or two. Yes, they're going to bring them up. Yes, there's a gentleman here who wants to say something. Yes.
Look. Test. Thank you.
We'll start with him and then...
Okay, during these presentations, there is two diseases which attract my attention: dementia, epilepsy. I think now that we have all the tools, are we going to stay just to observe these two conditions? I'm thinking it is hypothesis, it may be not true, but it should be tested. You see the movie which has given to us the story of Claudine. These diseases, these mental diseases affect leaders, potentially people who are potentially to be very smart, out of the box, are those who are most affected. Same thing for, I believe, in dementia. Now we have all the genetic, all the biogenetic, all the biochemistry, plus now the world data. I think it's time for us to screen it. Why? Further research can continue, but it's time that a good bridge, we look at how these diseases are coming. We see the number is increasing over time, but I'm definitely sure there is, as this last researcher pointed out, let's look at what is the pharmacokinetic reaction in the brain, who is affected such a people. It's a challenge.
Thank you. The gentleman at the back, thank you. Thank you.
Thanks very much for the speakers for the nice delivered lectures. We have enjoyed being here, listening to them. My question is actually being here, listening to them. My question is actually, in some extent, in some aspect, like a commentary. In the second aspect, looks like a question. Exclusive of the brain insult in the early life, in the natal perinatal time, passing through the middle age for patients coming to the hospital without being known to be diabetic, hypertensive, or using narcotics. And exclusive of the age-degenerative changes, we have seen a patient with no underlying cause of hypertension, diabetes, not use of narcotics, and he came with something like a kind of dementia which has been classified at the end of the clinical session as pre-senility dementia for unknown cause. So I would like to hear if there is anything like this term coming across. Second, are there any established readings or research done for sleeping apnea or hypoxia due to embedded problem in the airway anatomy, or for the ill behavior of some people who are adopting different positions during sleeping, which can lead to snoring and get obstructing their airway, using of pillows or extra pillows, leading to a kind of hypoxia, compared to the air pollution in some industrial countries, which reduces the presence of oxygen by a remarkable percentage. Is there anything like environmental hypoxia induced by air pollution or caused by sleeping apnea leading to early deterioration of not the morphology of the brain, but the function of the brain? Is there anything like this? And the third, is there any thorough, genuine research done under the title of poverty and mental health? Is there any specific foods which have been proved by research to be damaging to the function of the brain? Thank you very much.
Thank you very much. I think these questions are not only just very, very important, but they require another conference.
Thank you for your comment, Professor. Thank you very much.
Thank you. The summary to the answers is what I'll just say now, actually for the benefit of the audience. With regards to young onset dementia, it's a very recognized phenomenon. And dementia, as we know, has many, many, many causes. So we only know of the commonest in elderly, which is the Alzheimer's type dementia, which is degenerative dementia, but we also know the vascular dementia. And then we have many long list of encephalopathies and sort of autoimmune problems and other things. But we also have diseases, or causes that has to do with our lifestyle. And you mentioned drugs and alcohol exposure and toxic agents and all the toxic things that Professor Suleiman mentioned earlier that may start early, so on and so forth. They can lead to dementia later on in the future as well. So that's a host of things that can actually do that. So that's well recognized, and it's a big topic by itself. With regards to sleep apnea, one of the symptoms of sleep apnea is foggy thinking, headache, can't concentrate. So obviously it affects mental health. And that is why sleep apnea is an emergency for treatment, because it affects young people who majority of the time are overweight, but there are many people who are not overweight. They have sleep apnea because of nasal obstructions or other causes of hypoxia in sleep. And they need to be investigated not only by neurologists, but also by respiratory physicians who are in charge of the sleep studies that they do. And then treatment be advised, whether they will need ENT involvement to do some surgery on the airways, or whether they only need oxygen supply, such as CPAP, to be given to them so that they can have more oxygenation when they're sleeping and therefore combat the effect. And this is something that you can see in patients with sleep apnea. If they start having CPAP, the next day or after a few days, you start to say, my brain is clearer, my head is better, I can think better now. But if it's not treated and the disease is allowed to continue for ages, then certainly more brain cells are going to die of gradual hypoxia. And that can cause more progression of the dementia as such. So that can do it. I can't remember. The third question is related to air pollution. Well, air pollution is the same thing, chronic hypoxia, carbon monoxide poisoning and things like that. People who sleep in places where, especially in the cold weather, where people actually have hypoxia because they are staying in a place where there is not much of oxygenation. But if there are chemical toxins that are spread in the atmosphere that can easily cause sort of memory problems and may well be progressive as well, I'll ask Professor Suleiman to comment on that.
Before giving to Professor Suleimani to respond, I think just for dementia, I think for etiologies, we have a lot of etiologies that sometimes even physicians, neurologists don't not look for. I think that's part of problem of education, training. I think that's why I think we are focusing on training of specialists. I think that's one problem, part of the problem. The other part is that we have some etiologies not known. For example, it's like in stroke, I think we still have 20% of causes not known, even in high developed centers. I think also it's coming from the investigation used. For example, I don't know, that depends. I saw in very good universities and hospitals like you have in Rwanda, in North Africa, in the southern Africa, in Egypt, in other developed countries in Africa. I think we go till the top advanced examinations. And in the end, we have some unknown etiologies that maybe science could discover in the future. And just about sleep apnea, I think we have some very easy tools that we use. It's like to take the tennis ball on the back. I think that's a very easy tool that not cost any money. And we can, by example, use it, and it can reduce 50% of snoring and sleep apnea in patients. I think, of course, decreasing the obesity and the other factors. I think that's also the main of these conferences for prevention and also collaboration and South-South collaboration. I think that, of course, we have our friends from the United States, from France, from Asia, from America. But I think inside Africa, we have a lot of skilled persons, skilled advanced universities that we can work together and establish good collaboration.
Yes, just to complete this discussion, when we work with medical doctor, when we evaluate by a neuroimaging process after exposure in animals, we observe that by scanner or Erimen, we have not changed. But when we evaluate, we assess function of brain system and immune system, we constate, we observe that there is a change. That's why I think that it's important to consider predictive markers in biochemical and by process in biochemical toxicological exploration, because imaging is very difficult to identify change in imaging of a brain with the exposure to low doses. This is a function which altered, not structure, not morphological.
Yeah. Yes, this is a very, very important topic. I mean, neurotoxicity, now the environment is really getting more and more contaminated. It's not the underprivileged countries. Even the affluent countries are now, for example, I've been dealing with pediatric neurology for 40 years now, and we see a lot of children who grow with cerebral palsy, with autism, ADHD, and so many other diseases. Of course, childhood onset epilepsy. So the question is that there is definitely, Suleimani has already talked about it. I'm not going to expand on that. But the thing is that this is the mystery. This is the mystery. There's so many environmental toxins that cause hypoxic insult to the neurons, and the superoxides are damaging the brain. So this is very important. In the last many decades, I think the prevalence is not getting less, it's getting worse. Why? Well, for example, when I'm doing a lot of studies on autism, and we found that in the last, from my 40 years of seeing autistic patients, in the last 10 years, the population of autistic children have grown into dimension. I must tell you, we know there's little doubt that, for example, autism or ADHD or ASD disorders have a genetic basis. So the genes predisposes the neurons to the environment, environment and toxins. I must tell you, both of them play an important role. This is very, very important. And this is why Dr. Suleimani's session was extremely important. We must get down to what is causing the hypoxic insult.
First of all, I have to say this is a very impressive gathering in Africa for Africa, which is a slogan raised up a long time ago and now is coming to reality. The dimension of looking at brain health is actually multifactorial, not even before you are a full-born human being. From the time of somebody gets engaged or married to a lady, from the time of early conception, from the pregnant women in Africa, from the delivery in the rural areas where there is no care or even they are exposed to, from the time they are babies, vaccination, education, and how they are treated and the services provided. The spectrum, it's a big continuum from the time of somebody thinks of creation of mankind till today. And I'm in the way saying in Africa, we are not only on the receiving side, because this has been a big misconcept. People come from the West to teach us about diseases in Africa. Tropical institutions are based in the West about diseases in Africa. HIV problems treated and research is done outside Africa. I think now the time has come for Africans to realize that we should be the ones to lead into research. And what Dr. Suleimani said, I really admire, because food in Africa, how many researchers you have seen about food in Africa and toxin in it? How many people know what are the neurological complications for scorpion sting or snake bites? Which snakes are dangerous? What you will do to them? Who knows about these heavy metals and the rare, very expensive metals stolen from Africa? How they are mined for? How they are produced? How many people are exposed to them without knowing that they have been damaging their brains and their nerves? I think the new generation, you should look into researching into these facts and bringing them to reality. We are not on the receiving side. We should be on the giving side. We have, I can't say we have our own medicine, but we have our own problems, which now we are aware and we are capable of researching. Now we call into governments. We call into people who are holding the pen, those who are holding the money. They should give more money for environmental research. They give more for neurological research. And also I mentioned about the ICAP, which nobody has mentioned about so far. The ICAP is an intersectorial global plan for neurological disorders, epilepsy and other neurological disorders. This is a 10-year plan endorsed by the WHO, and money has been allocated to it, extending from 2022 to 2031. There are many entry points for grants and for money and for support from WHO and from local governments. I cannot take over to talk about IGAP now, but I think what my colleagues, they pointed out is important to incite generations to come. Those whom I always call, you are the bulk of our day, but you are all our future. Please think of introducing this toxicology, environmental, planning, IGAP, community, nurses, non-medical people get involved in treating patients because we don't have enough doctors. All these should be fostered by local governments. I hope there are some officials here hearing what I'm trying to say. Also, people in the universities, they should introduce this in the curricula, because in the curricula of many universities, there is very little about talking about brain development, effect of environment, effect of food, effect of these things. I hope I have just thrown big lights into something which should be our aim, and we will be discussing some of them during this conference. Thanks to those who made this a reality. Thank you very much.
Thank you very much. We have one more question. We are running out of time.
Thank you for the excellent presenters. I just want to pinpoint one aspect that she mentioned. I think those guys, they already have the setting. They have everything. I think the last is we need, he said, brain is time. So if we have University of Science, Technology, they want excellent, They want to make it sustainable. The brain is excellent. Those guys have excellent knowledge. They have amazing laboratory like the one in Europe. It's just about going here, 8 hours flight copy, and bring it to Rwanda. Not more, not less. That's the message.
Thank you very much. One more question. Let her ask a question and then we can.
Okay, I just have two questions come to my head when I follow Dr. Abdallah, Dr. Sulaimani. It's come to my head, this from my background as a medical laboratory scientist and as a researcher at the same time. So what the role of the advanced technology like genetic diagnosis or flow cytometry technique and early diagnosis of or early detection of brain disease? This is the first question. The second question is, when I heard from you talking about nutrition, the link between nutrition and brain health. So is there any research about gut-brain connection or brain microbiome? This is my two questions. Thank you.
Thank you very much. Very important question. I'll answer the last question first. With regards to the gut, you may remember actually, if you read a lot about multiple sclerosis in children, the Helicobacter story and everything else, this is all thought to be related to some gut infection that may predispose to susceptibility of multiple sclerosis in children. And that study is now being escalated to see what role this infection may have in adults, even though we know in adults we're primarily blaming Epstein-Barr virus for that. So gut infection and neuroscience is very much linked, especially in children. Okay, so with regards to the need for highly scientific advanced tests, actually, as you remember, majority of the diseases we can't cure, we can manage. And if we know we can diagnose them early, we can predict how they can affect the patient in the future, and we can look at methods to cope better and to prevent complications of those diseases. That's the benefit of these diagnoses. Of course, they may have their pros and cons, because if you diagnose with a genetic disorder, then you have to think of your family. How are my children going to be affected? How are my siblings going to be affected? And so on and so forth. And that is why, at least in the UK, I don't know about here, nobody undergoes genetic testing without genetic counseling. Okay, so that genetic counseling will enlighten everything about the situation. And also back home in the UK, we have the issue of insurance. So if I'm suspected I have a family history, let's say of Alzheimer's disease or motor neuron disease or whatever, if I go for life insurance, then that will have negative effect on me, for example. So all these ramifications have to be considered, but it makes people very, very aware of what's happening. In fact, I'll give you one scenario. Only a general practitioner wrote to me 2 weeks ago to say to me, somebody died of motor neuron disease and his children went and had genetic testing and confirmed that they carry the genes for motor neuron disease, but they don't have it yet. How do I advise they look after themselves? That's the question. Now, this motor neuron disease is an incurable disease and may lead to death early in life and things like that if it happens. But because they are asymptomatic, they are not my patients yet. They are not neurological patients. So I had to refer them to a geneticist who can talk about the pros and cons of what they know and how that may have implications in their families.
Thank you very much, Chancellor.
Just to add on genetics, of course, one of the most important aspects of genetics is the era of precision medicine. Now, through genetics, if you can pinpoint the defect at molecular level, you can target that by specific treatment. And this has been well documented in Dravet syndrome. Of course, genetic counseling is so difficult because most of the neurological diseases are polygenetics and complex. And therefore, to study one disease in one family, it is so difficult and so consuming, and it takes a lot of financial support. This is one comment. The other comment I want to make regarding the effect of neurotoxicity. One of the major problems we see in Africa is mercury poisoning related to extraction of gold in a very primitive way. And this is very common, and it should be stressed and it should be discussed further.
Just to add one point, I think about the new advances in technology, we have also artificial intelligence. I think countries like Rwanda, like Morocco, like Egypt, many countries, for example, we can even find new genes. Now we have example for new pediatrician disorders, like Professor Arif said. We can have some machines just doing face recognition, and they can even give you the diagnosis of the disorder. I think that happens to me in one patient. We discovered the disorder just regarding the face recognition. And after that, we went for the gene, and it was the right genetic disorder. We can have also a lot of other techniques. For example, when we are bringing samples to biology lab, when we have the AI included in that equipment, sometimes the machine does not only give you the result of the assays and the diagnosis of the disorder, it's also helping you to make curves and to make a lot of analysis of studies, and also to help in producing research coming from these samples.
Thank you very much to the professors. Thank you for your answers. Thank you to everyone who posed a question. You may please take your seats. We're heading into the next session. I would like, thank you very much. A round of applause. A group picture, just 1 minute. Stand on the group picture. Group picture, just 1 minute there. Well, smile for the camera in front. One picture. Thank you very much. Thank you very much. Now we're heading into a very insightful panel discussion. I would like to call Dr. Frederick Katira to spearhead this next session. A round of applause.
Hello, hello. Good afternoon, everyone. Now, disclaimer. This is about the time when we eat lunch. And with regard to the brain, there's a distortion in concentration. So if you try to make me happy and I try to make you happy in this conversation, we shall go a long way. So don't worry, lunch has been prepared, but let's make the most of being here and enjoy each other's company. Is that fair? All right. I'm Dr. Frederick Katera. I'm a public health specialist. Okay. And it's a privilege to be here. I want to celebrate the organizers of this conference. It's not very common that we can really gather leading brains on the continent and across the continent to discuss brain and well-being. So this is one of those rare beneficial investments that I want to celebrate. For everyone who has put it together, congratulations. Now, I do want to invite a panel to discuss some of the more community-based aspects of the brain and mental well-being. We've spent a lot of time listening to professors who are more lab-based, technical people, but at the end of the day, the patient only spends maybe 20% of their time in a facility, 80% they spend it at the community. And if we are not able to marry both of those aspects, we will not be doing justice to the group. So I'm going to call a couple of panelists here. They'll introduce themselves, then we'll have a conversation. Does that sound like good? All right. So I'll begin with Dr. Mark Nyanzu. Please make your way here. If I pronounce your name wrongly, my apologies. The second colleague is Chantal Kanyabutembo. The third colleague is Professor Tahir Obeid. And then lastly, but not least, Shamsa Kazimhaya. Please make them comfortable, make them enjoy the conversation, and let's take this to another level. Oh, I need a chair. Can I get a chair? So I'm going to give them the mic. I'm going to ask them to introduce themselves, their role, and how they are liking this conversation, and maybe just ask them to give a few reflections on stigma in their own practice. I'll begin with Dr. Mark. Please go ahead.
Thank you very much. My name is Mark Nyanzu. I come from the UK. brain surgery there. I'm here very happy.
Thank you.
As far as stigmatization is concerned, I'm not sure there's much in neurosurgery, but I'm sure as the conversation goes on, I'll have more time to express further. Thank you very much.
Welcome.
My name is Chantal Kanyabutembo. I'm among the founders of the Epilepsy Alliance Africa, include the National Bureau for Epilepsy Rwanda. We started it in 2016 under the leadership of Dr. Binagwaho, and then regard also Dr. Gashumba. After, I think within Binagwaho, we did this program just by starting it, but we tailoring and continue it, and the program still existing. Thanks a lot to see the MOH team attending and endorse this good resolution coming from the World Federation program like the Mena Brain Week Mental Health, which is a platform bridging many skills. No communicable disease, no stakeholders, as the global health introduced a topic to say that we need to take the patient as a stakeholder in our country, and we need to reduce the stigmatization. So if you see the role model, I've introduced it to the MOH of Rwanda with the help of Dr. Gashumba and others who came after her. We introduced a model where each district hospital in Rwanda has to have a cooperative group program for patients. And those patients, we need to increase the nutrition. We know that the cause of epilepsy also is based on immunology, and we need also to improve such way of people, the way they can take the drug, also balance the nutrition. Another aspect we did is about to increase the tools for the diagnostic. That was with me and Dr. Violette and also Dr. Fidel Sebera. I think my accent is not good, but what I did, I'm not afraid to speak on basically all which we have done under the EGAP and the action plan.
Thank you.
So in 2016, we get a resolution under the WHA Assembly, which said that we need to consider the patient as a stakeholder and make the national plan action for it. And thank you for Dr. Kaite Shonga, include Dr. Darius, who continued the program about epilepsy action plan. And today I found that even Dr. Fidel Sebera accelerate the program under the UR, include Dr. Stefan, regard the research, and also trained by 4x4 other trainee junior doctors. So what I'm helping is to bridge the gap, considering the time they are spending to treat patients at hospital, same time producing article. We need to be also responsible as a patient. We need to produce article. We need to improve the mechanism of managing such policies of the health. Example for the school, I did so many articles about the school program, the safety guard of the children. And we came across some case where we found a children, there's no medical record of the children at school. But that is not something very difficult to endorse and make plan for it. But we did a lot, and we think that the government will endorse it, because in Rwanda, we don't hide our identities. We reveal it and we copy. If we find Zimbabwe is good on education, we'll tell them, please come. And it's the same of the Middle East. You see the example of Dr. Suzanne and others coming. Those are the Middle East and also the Mediterranean. What they did is an amazing, and I learned a lot from the program.
Thank you.
Others, it's about to improve the telemedicine because we have more misdiagnostic, and that was revealed under Abbott. And I think Rwanda has a 600,000 patient under anti-epileptic drugs revealed. The prevalence is very high, as Dr. Darius said, and we are going to the 4x4 program, improve the Ibuzima, that will be, and I think on curriculum agenda, we need to thank also the First Lady of country, because the inclusiveness she brought on matter of people with invisible disabilities, mental health is very high. And I thanks a lot to the MOH.
Thank you so much.
And Dr. Darius, include members of the Alliance Africa.
Let's just yeah, we'll come back to you. Yeah, Prof. No worries. Yeah. Thank you.
Of course, stigma, one of the most devastating problem which patients with epilepsy faces. And this stems from the fact that epilepsy had been daunted 3,000 years before Christ as related to supernatural power. And this concept is still practiced by many people, especially face healers. And I encountered a patient just 2 months ago who was diagnosed by a physician as suffering from epilepsy. She was put on anti-seizure treatment. Initially, she developed side effects. She dropped the treatment and she went to a pastor who told her that your disease is not a medical disease. Don't take any medication, just come to my prayers. So one of the important things to approach is to go to the level of faith healers. They play a very important part in disseminating this concept of supernatural power. Of course, there are so many types of stigma in epilepsy. One of them is the self or personal feeling stigmatized. A patient with epilepsy thinks that his character is damaged, he has low profile of himself, no confidence, and we need to take these people out of this feeling. Also, there is the interpersonal attitude. For example, families. Families, they think that their child with epilepsy is not a normal child. Probably he shouldn't go to the school. And this happens in many societies. Also, the part of stigma is by institution, by part by the government body itself. For example, there are rules in some countries which does not help patients with epilepsy to take certain jobs. So to approach this problem, this is a very important part which might affect the patient more than the epilepsy itself. And there are so many programs which are done by EBE internationally and EGAP recently, which are addressing this problem. Just as the end, I need to mention the Epilepsy Day, which is very important for education of the people in general.
Thank you so much.
And
Thank you so
usually
much.
it is done on the 13th of November. So I encourage my colleague, Dr. Chantal, to make an Epilepsy Day a very important event in Kigali.
To advocate for epilepsy, I completely agree. So I'll just go to Shamsa. So what is clear is, apart from a diagnosis a clinician makes at a facility, when the patient goes back home, there's a whole ecosystem of enabling factors or even risk mitigation factors that we need to employ. And many times that's where the bigger gaps are. So Shamsa, just tell us about yourself and some of your work and feed into that conversation of basically stigma for this kind of patients.
Sure, thank you very much. Good afternoon. My name is Shamsi Kazimbaya. I'm not a researcher. I'm not a professor. I'm not a medical doctor. I'm just a gender expert. I work as senior fellow programs with an organization called Equimundo, Center for Masculinities and Social Justice, based in Washington. But I'm based in Kigali, and I do coordinate the work around across Africa, basically. And I've been in this field for now almost 15 years. Thank you very much to the organizers for this invitation to be part of this amazing conference. I'm really very happy to have this panel after the many amazing panels with the researchers sharing the amazing research findings and all that. But I'm really very happy that we are now here to bring in this other equally important dimension, talking about the real situation, the communities, in our families. Because it's true that we need research, we need findings, we need all what we've been hearing this morning, but we are talking about people, actually. We are talking about people, we are talking about relationships, We are talking about roles and responsibilities. And all this comes to actually complement what is being done by the professors and the researchers and the health or clinical part of it. So what I'm going to share today is that actually bringing this cross-cutting lens to this conference, which I think is really very important, and call upon the following, the next discussions that are going to happen in the next days to make sure that this cross-cutting theme or discussions it's not missed out.
Yeah.
Because after having seen those patients and those people with health issues, they at the end of the day they go back home,
Yeah.
whereby actually they have to deal now with these relationships and those gender dynamics. And you were talking about how much gender norms and the whole construction of masculinities shape the way we live with those situations. Specifically today, we are talking about epilepsy, we are talking about HIV.
Yeah.
Many or most of the previous speakers talked about stigmatization. They talked about isolation. We are living, I'm talking about Africa now, but actually it's equally also, it happens in other continents, other situations and countries. We know that we live in a very hierarchical system. Here I want to talk about relationships between men and the women. The place of men.
Can you give a few examples so that we can all relate and put a face to it? What are some of the common examples you've met in your own journey?
Yes,
without
sure.
naming names.
Actually, I wanted to share about the experiences of men basically, because as I said, we do focus on gender issues, but mostly focusing on masculinities and trying to rethink about how to reshape or to redefine what it means to be a real man. In Africa, we know that a man actually, like, what is a man? He should be strong, he should be tough, he's a provider, So when it comes to issues of health, we see that when we are talking about, let's say caregiving, it has a feminine face. When we talk about those, people we're having in our homes and families, when there is an issue, in a person has those issues, it's going to be the woman who's responsible, who's actually having the whole burden of, taking care of, being the caregiver actually in the house. And the man, some men will just going to be the one who provides financially, basically. But all what goes with caregiving is just for women, which affect very much the mental health of everyone in the family, actually. This social pressure to the man to provide financially and all that, but also this pressure from the community and the family for the woman to be responsible of taking care of all that. But also on the other hand, it also has its own negative consequences to men. Men being that definition of men in our societies, who should be tough. It's very rare to see men seeking for services, health services or care services. So the man should just be in the home because he shouldn't be showing that he's sick, he has to show that he's strong. And afterwards, the consequence will come to the man. Again, we're talking about well-being and mental health. So actually, just to say that it's really very important to think about those issues around gender dynamics, gender norms, masculinities, to come and make sure that they complement all the effort that you're trying to do to advance brain health, but also well-being. Thank you very much.
No, thank you so much. A round of applause. Mark, I don't think we gave you enough time. I'll give you some airtime, especially with regard to stroke in particular, even if it leads into epileptic symptoms. What is very peculiar, and what are some of those same challenges people have in communities when they're back home?
You almost want to jinx my talk for tomorrow. But what I really want to say is that to take you a bit away from stigmatization. Because with neurosurgery, when it comes to us, almost everybody doesn't want to have brain surgery. And the main factor is that the outcomes are always not great in certain parts of the world. And I'll give a personal experience for myself. I trained somewhere in China, and I returned home to my country, Ghana. And for 1 month, almost every neurosurgical patient that had operation did not do very well. And that is to say the least. When I say not do very well, the outcome was just bad. And that sort of experience put people off not just patients, but even for trainees and students. Yeah. But in certain parts of the world, the outcome of neurosurgery is very good. Yeah. So I guess the point I'm trying to make is that if we get it right, we can do a lot for patients with neurosurgical problems.
So what makes that difference in outcomes between the West? Is it that we manage more severe patients? Is it that they come to us rather too late? Is it a capacity issue? And maybe just to, how would you talk to a family in Rwanda, in Ghana, who have a
Yes.
patient who needs a brain surgery
Yeah.
with that knowledge of poor outcomes? What does that look like for you?
It's multifactorial, really. It's a combination of things. Since I've been here, I've asked myself, what's the population of Rwanda?
14 million.
14 million. And how many brain surgeons we have? Maybe less than 5.
Less than
also.
5 for sure.
So it's very difficult to answer this question, and I'm choosing my words carefully because
Because I mean, we're trying to fight stigma here.
Yes.
If I feel like when I appear at your table,
Yes.
I may not wake up.
Correct.
Chances are that I will not come, even if it would have benefited me.
Yeah.
So there has to be a strategy.
Yes.
To really get me to a level of
Yes.
trusting in
Yeah.
the outcome.
Yes.
Or else I will stay at home
Yeah.
with whatever moribund situation I have. Yeah.
I think we are doing the right thing in the sense that we are bringing in experts from abroad. And these sort of collaborations are very important, yeah? So there's transfer of knowledge base, you understand? If you operate, for example, if you do brain surgery or spine surgery, you have to do it properly, yeah, to get a very good outcome, yeah. And you see, there are trainees, there are people who are being trained in Rwanda to be brain surgeons or spine surgeons, but you might go through your training or your program for 5 years or 7 years, and it's not all the conditions that you will come across.
So you don't have basically a good exposure
You don't
in
have a
terms
good
of cases
exposure.
to develop your skill set.
Yes.
Okay.
Let
Maybe
me
I'll-
land before
yeah,
that,
please.
before I let you go. The reason why that is so important is, one, is the field of neurosurgery is expensive. Yeah. So if you have a particular problem and you don't make it to the hospital because of the financial constraints, it means that somebody doesn't even learn from that sort of experience.
Yeah.
So I'll leave it at that. So you can
No,
move on.
that's helpful.
yeah.
Maybe
Thank
I'll go to Professor Tahir. I think you did mention for an epileptic patient in the community, apart from a medical diagnosis, there are other factors in play. Supernatural convictions. You talked about some of the faith healers, and I can imagine witchcraft is somewhere not far from that conversation. And the question I have is, now that those are traditional beliefs in communities, which we are not going to eliminate tomorrow, how do you work with those same fact people in order to form a community of practice around that patient? Because ultimately, patients will first go to the other group before they come to you. What are some of those community-led initiatives that have helped working with them to destigmatize the whole problem, but also to allow patients to come to you for care?
I think one of the most important thing to do is first don't make these enemies, make them your friends, and try and visit them, talk to them about still they have role, and their role is to tell them their role is very important, that they will advise the patient to go to the correct specialty. At the same time, you have to educate them about what is epilepsy, because it's still in their mind, it is supernatural power. And this is not only in Christianity, even in Islam. And of course, one of the things in the Bible mentions that our prophet Jesus took a devil or a shaitan out of the head of the child.
The child, yeah.
And even in Islam, some scholars, they align this with also supranational power. We did a study in Saudi Arabia a long time ago among highly educated people, and around 40% of them, they think that epilepsy is supranational power. So it is very important to communicate with this faith healer, to make them your friends, invite them, visit them, encourage them, and so on. And with their help, they can do a lot of things to help the patient and the community.
No, yeah.
Let me answer this question. We did the studies with the Epilepsy Alliance Africa, the name of the epilepsy, the narrative, the meaning, and such article produced in, it was produced in 2020 during COVID. Even in Rwanda, we call it Igichuri. That means a brain in the wrong position.
In the wrong position.
Flip down. In the only country which does not stigmatize epilepsy is the Swahili, Kifafa. But other country stigmatize epilepsy, Evo, etc. Even in the language of Dr. Najib, they are Arabic. It's like you are possessed by demon. So for me, what I can say, stigmatization, this part of education in the civil society still exists. When they refer a patient to the practitioner, the primary cares, we can find many patients in Rwanda still practice the traditional healers. So they put some hot spots, knife, metal on the head of the child. They say that is to cure the migraine. But we need to implement a strong policies, guideline. When a doctor found it, or even a teacher school, they have to report it to the social affairs.
Yeah.
And the social affairs are the Bagondera Buzima, the non-stakeholders, both by the partner in health. And that will prevent the abuse on the child. It's like what they be doing in Ethiopia, places like Ethiopia and Somalia and other places, Sudan. They used to be doing women mutilation. But in Africa, there are other places in Africa where they can take a child. They take, for example, a piece of a cloth or a piece of a part of a skin, and they bury it somewhere, or a hot knife, or they kill a goat and they speak those bad language. And that child will grow up knew that is possessed by a demon.
So basically, it is
even drinking the drug.
Yeah, it is.
They will not believe that it will be a healing process. Another problem here in Rwanda, maybe some pastor exaggerated the miracle. And I thank the president of the country. Yes, my God has healed me. I'm not denying miracle. But some of the patients got even misguided and removed. Even sometime after go to the chambers of the prayers, the following day they stop the levetiracetam. The consequence of it is a heart attack or high, like the epilepsy they will get will be malignant because they stop straight away.
No, I hear you. So basically, even if someone says I'm healed, whatever that is, they need to go to a medical facility to have that verified and to be linked into care, and that's still a need. And that's what he was talking about, engaging with these other faith healers, and they're part of the ecosystem.
Another stigmatization which I witness in Rwanda.
Just one, and then I go
I will go to her. Yes, let me finish. Another stigmatization I witness in Kabuga school and other in Nyamirambo. A girl was dismissed at school because of epilepsy. Even myself, that has happened to me at national level program of GCSE. I faint, it is an absence. The absence is not like the tonic seizures. Then my exam, at that time it was after the war. We still construct the country, but I could not pass my A level. I need to repeat it. But other children, they are still dismissed from the board school. And the board school say, we don't want to take responsibilities of this. But that children get recruited at a school in Nyamirambo, another one for the Middle East, sponsored by the Qatar, and that school look after them. They call on us. We go there to explain about the first aid. Then they show us 2 cases of the student. And those students today, we save them to the telehealth with Dr. Najib. And they passed the DGCSE today, they are at universities.
Yeah.
Let's congratulate the fellowship program,
Yeah.
remove the stigmatization and give priority chance of developing a positive journey.
Yeah.
It's like myself, I'm here in Rwanda. I'm the one started the National Bureau program as a patient, but on panel discussion, we need to have many patients.
Yeah. Patient
capable.
voices, yeah.
And example, Valant Adiembo, she's a lady from Kisumu, Kenya. By learning on the model of the Alliance Africa, what I've done with Rwanda under the MOH, now they have even the visibility and they get even treatment free from Raw Foundation.
Yeah.
We need to clap from Raw Foundation. It's a good organization which save many lives. Thank you so much.
Thank you so much. Maybe Shamsa, I just want to, you described some of the gender-related consequences of some of these traditional beliefs, including things like health seeking and the strongman syndrome. I don't know whether you call it a syndrome, but can you also prescribe a medication? There's describing the problem, and then they're saying, okay, maybe the way to reverse what we are seeing, these are some of the initiatives that we can do to undo that society bias and tradition that enhances the stigma. Yeah.
Yeah, sure. I think it's all about changing mindset. And to add to what the colleagues have just said, I'm actually seeing 2 ways of trying to tackle and to try to strengthen the impact, but also trying to be effective in what we are trying to do in terms of response, basically. So you talked about the issue of those traditional healers or religious or faith leaders, which in Africa, they are really very influential.
Yeah.
They influence a lot all the decisions of what is being done, in what we are doing. So I think for all of us to try to be successful, it requires to take a multidisciplinary approach.
Yeah.
Not only the health or the clinical, but also involving everyone. I think someone said it this morning, saying that actually health, in general, health issues is everyone's business. Not only doctors, not only professors. So meaning that actually it requires to take a kind of, to work with the whole ecosystem. Not only the clinic.
Yeah, yeah.
The clinic does its part, but the community has its own part to do. The government has its own part. And what I think, and I've seen this being successful even in other countries, including Rwanda, of course, when this structure is clear and functional, it's really very helpful.
Yeah.
Like, for instance, as she said, Rwanda has its own way of doing things. Like those, so-called pastors or, I don't know, traditional healers, they can't know their business anyhow. There is actually a way of, structuring and being sure that they do it, in the right way. So I think this can be one of the strategies to be able to handle that. So coming back to the question, I think what you're trying to do in what we are doing is trying to transform those kind of, negative norms and behaviors.
Okay.
By doing what? By sensitizing across all those. But of course, when they have this buy-in, it becomes easier to sensitize men, women in the community and make the issue not someone individual issue, but being a family or a community issue. So, for instance, we talked about accessing. We know that in some countries, including Rwanda again, services are available.
Yeah.
But there's still a problem of accessibility and affordability as well. But when it becomes a community, a family issue, again, talking about gender dynamics, if the man feels and, understand that also he's responsible, especially because oftentimes he's the one having money, actually things become easier, and the person who needs service and care and everything can easily access to those services. So mindset, sensitization, and make it actually everyone business, not only one person, one family business. Thank you.
Can we maybe get 1 or 2 questions from the folks down here? Going 1. Any questions from the floor? Going 2. All right, my last question, maybe I'll ask Shamsa in particular. We've talked about, especially we've focused on epilepsy.
Ask them in Kinyarwanda because it's the
haba hari umuntu ufite ikibazo hano ibyo twaganiriye, even if most of these questions were in English. Anyone? Okay, there's someone. there's a, who can give him a mic over there? But I just want to ask Shamsa, we did not talk about HIV much. In my early career, I was actually an infectious disease epidemiologist. Right now, when you talk about HIV, it looks like the problem was solved years ago. What are still the current stigma-related matters around HIV, even as we get the question from this gentleman? Yeah. Oh, do you have a mic? Oh, okay.
Thank you very much. My question goes to two ladies from a gender perspective and then to a neuroscientist, if I'm not wrong.
Yeah.
I was wondering, since women are the ones to conceive and our nervous system starts as the embryo starts, how does the mental health of that woman affect that embryo to the level of affecting our nervous system at the end? And then I was wondering whether the social norms, because normally we are talking about social instead of science, from your own experience or implemental experience of doing surgery, mainly brain surgery, between men and women, who are the most affected, and what might be the reasons of that difference? Thank you.
Thank you.
Do I
You
go
first,
first?
and then.
They say ladies first, yeah. Yeah.
All right.
More clinical. Okay.
Yeah, all right. Good question. Excellent. The array of neurosurgical problems is plethora. There are so many of them. To say that there's prevalence in female more than male, it's a very difficult question to answer. But clearly, there are certain conditions that one supersedes the other. Yeah. I will not bore you with which one has more and which one doesn't have more, but the answer to the question is that it just cuts across. There are certain diseases you find them more in males, there are certain diseases you find them more in female. Yeah. As far as the developmental stages are concerned, yes, there are a lot of conditions that develop as a result of the state of the pregnant mother. Things like spina bifida, which at the moment are well dealt with things like iron tablets, folate supplement, and even depression and things like that. My neurologist colleagues will probably talk to you more about that. But being in a good mental health state for a pregnant mother, it's very important, because it's just the development of our child in the fetal stage is very important for that aspect. So really, in our part of the world, especially here in Africa, because we don't have a holistic medicine, it makes it very difficult. And sometimes you are the mercy really of luck. And if you believe in God, then you say you are the mercy of God to see you through. But in certain parts of the world where they take matters in their own hands and believe in what you call evidence-based medicine, then there's a lot of things that go into play from the moment a mother becomes pregnant, or from the time you start thinking about conceiving a child. You go through a very good primary care system where you are fully well supported to avoid a lot of this. And certain pediatric neurosurgical conditions, for example, you still find them in abroad. You still find them in the Western world. But the thing is that there's good support system. Yeah. So things like cerebral palsy, the state at which a mother delivers, hypoxia, when a child at that early stage, the brain is friable, although we know that kids, bounce back very well because of plasticity and all of those stuff. But that notwithstanding, it's just difficult, really. If you look at it on all terms and all levels, we just need to do more as an African continent. And somebody mentioned it so well during their presentation that we need to take things into our own hands now. The research should be done by us. It should not be done by sorry to say again, by Westerners and Europeans.
It should be more relevant in
It should
this
be more.
setting.
It should be us. We need to produce the money to
Yeah.
do the research to help our own people.
Yeah.
But I must say that we're in a momentum, or we're in a paradigm where the African is sort of seeing that, only that we're going at a slower pace.
Rate, yeah.
But I think by and large,
And we need someone to throw some money at us so that we can be a bit
we can
faster.
get there.
One more response from my able. Yeah.
No, we don't have time for
No, we don't have
other
time. Yeah.
questions.
So what I want to say, for example, the way he say about it, the conception, we need to prevent, as Dr. Tahid explained and Sehid, we need to prevent those risk assessments. Example, in Rwanda, we have the genocide in 1994. Majority of the women passed to PSTD, post-traumatic disorders, and they are carrying more comorbidities like anxieties, a lack of sleep, stress, etc. When that woman fell pregnant, we have a program on MOH on prevention of maternities, I think you know about. And we need to introduce the psychotherapy of those women before conception. So we know exactly how to, we need also to check because sometimes you can check the level of the stress of a patient via different symptomatic. But you need to make sure that that patient is a particular patient. Sometimes we need to deliver the baby at 7 months, like a woman with a diabetic. And we need to have a specialized nurse who can know exactly how the brain of the baby is developed, even how, sometimes we need also to have a genomic research regarding past women who have already given birth. Then we can know exactly which kind of protein they need, because sometimes we can give them some protein which can affect the baby. And for me, I believe that Rwanda is going to the right pathway. We are not high skills on internal medicine like other countries, like let's say Ghana and North of Africa. But for me, even Senegal is better today. But for me, I think Rwanda is shaping its future, not regard nationalities, but anyone is welcome to help us. Then we learn from them and we move forward. And I think in few years coming, I think we're gonna produce more article accurately regarding the genomic research. And thanks for the RBC to adopt it with the China. And soon we'll bring also the public health in England. Thank you so much.
Thank you. Guys, I'm so sorry we have run out of time. I'm under pressure from the organizer. So wrap it here. A round of applause to the panelists here.
Yes, a round of applause to them.
Thank you so much.
And thank you very much to moderator, Dr. Frederick, for moderating this panel. And I'm sure we've learned so much. So it's time for lunch. I would like to first call upon the VIPs, those in the front and second row, to please stand up. Two people, Leila and Ahmed, are going to direct you to the cafeteria. So we'll give them approximately 10 minutes for them to leave. The rest of the people in the auditorium, you could use this time to use the restrooms, to network, to speak, and then after 10 minutes of the VIPs leaving the room, we can follow for the rest of us to have lunch. Thank you very much for your cooperation. The first two rows, you could please proceed. Even you, gentlemen, the first row, yes.